of the question, okay, so one of the question must be from the nerve part, so let's revise it. So here you can see this, this is the question in which the relation of humerus has to be matched with the nerve. So there are 5 options. I want everybody to mark the right answer. Distal end of humerus related with the radial nerve, surgical neck related with musculocutaneous nerve, radial groove related with musculocutaneous nerve, medial epicondyle related with ulnar nerve, scapular notch with suprascapular nerve. So I am here to explain the answer, but I want you to give a quick answer, those who are able to understand. So yes, many of my dear students are giving absolutely correct answer, and the correct answer is D. Yes, very good, dear students. Yeah, medial epicondyle. Yes, that is the right answer, that medial epicondyle is related. Yes, dear. Sorry, medial epicondyle is related with ulnar nerve is absolutely right answer. Is absolutely right answer. Now, let's focus why other options are not right. Distal end of humerus is related with radial nerve is wrong. Distal end is related with medial nerve. Surgical neck is related with musculocutaneous nerve. Musculocutaneous nerve is the nerve of anterior arm. So can anybody tell me which is the nerve which is related to the surgical neck of humerus bone? What is the name, dear? It is the axillary nerve. Radial groove means the spiral groove. It is related with radial nerve. Absolutely. And scapular notch related with suprascapular nerve is wrong. The better word will be suprascapular notch related with suprascapular nerve. So we have got D as the correct answer. So which is the correct answer, dear? D. Yes, axillary. Yes, you are right. Surgical neck of humerus related with axillary nerve. So that is why we will mark D as the correct answer. Now here, I just want everybody to see this image. This is the image of a humerus bone. और यहाँ पे humerus bone में आप nerves और vessels के relations देख सकते हो. So what you can see that if there is a fracture of the surgical neck of humerus, the potential damage or threat is to one nerve and artery. What is it? The nerve and the arteries which can be damaged is axillary nerve and posterior circumflex humeral artery. So in the surgical neck of humerus, we have got the damage of, at this location, there is chance of damage of axillary nerve and posterior circumflex humeral vessels. Yes, absolutely correct. In the mid shaft area, that means at the shaft area of the humerus bone posteriorly, there can be chance of the damage of radial nerve and profunda brachii artery. Radial nerve and profunda brachii artery. Very good. If I talk about injury of the medial epicondyle, it is leading to the injury of ulnar nerve and ulnar collateral artery. So only we have marked ulnar nerve and medial epicondyle as the right answer. Supracondylar fracture is a potential threat to the damage of medial nerve and brachial artery. Okay, here you can see this is an image where you can clearly appreciate. So in this image, you can clearly appreciate that median nerve is related in the distal end of humerus bone. It is related in the cubital fossa medially. Radial nerve is more towards the lateral aspect, and ulnar nerve is related to medial epicondyle. So these are in relation to which bone? Humerus bone. This is actually this diagram. If I enlarge this diagram, my dear students, you can see this is suprascapular nerve and suprascapular artery, and this notch is suprascapular notch. This notch is suprascapular notch. Suprascapular nerves are giving innervation to these two muscles. What is the name of this muscle? Supraspinatus muscle. And this is infraspinatus muscle. How we are knowing this? This is the spine of scapula. Posteriorly, this is the spine of scapula, and the muscle which is lying above the spine of scapula is supraspinatus, and the muscle which is lying below the spine is infraspinatus. Okay. Now other important topic. What I told you about upper limb. Agar upper limb ki baat kare, so the most important topic is the brachial plexus and the nerves. Okay. So let's quickly revise it, brachial plexus and the nerves. I have already taken this class and in detail I have explained it. So let's quickly revise it. Okay. So now everybody can tell me the answers. And if anybody is not understanding anything, they can tell me, ma'am, please explain me once more. So here C5, C6, C7, C8 and T1. What is this? This is which part of brachial plexus, my dear students? This is the root of brachial plexus. Now C5 and C6 is joining to form upper trunk. C7 is forming middle trunk. C8 and T1 is forming the lower trunk. Now this part is the division. This part is the division and this part is the cord of brachial plexus. Now each of the trunk divides here, A for anterior and P for posterior. So yellow color is for posterior division of all the three trunks, and posterior division of all the three trunks will join to form which cord? Posterior cord of brachial plexus. The anterior division of lower trunk will form medial cord, and anterior division of the upper and middle trunk will form the lateral cord of brachial plexus. So we have already studied this. I'm just wanting to revise. Yes, Bell's nerve. Bell's nerve, the name of Bell's nerve is the nerve to serratus anterior. Bell's nerve is nerve to serratus anterior, which is also called as long thoracic nerve. Got it? Now, my dear students, we have quickly revised the formation of brachial plexus. If you remember, I told you the location of root and trunk is in the neck and the location of cords of brachial plexus is in the axilla. Okay, Akshay, yes. So exactly, quickly, let's see. Actually, I am taking one image, empty image. Why? Without any kind of labeling. Why? Because we have to revise all the branches of different parts of brachial plexus. So all of you just see this image and we will just revise all the parts. So now, as I have told you here in this diagram, this is C5, this is C6, this is C7, this is C8 and T1. So this part or the component of brachial plexus is root of brachial plexus. Everybody, okay? What is this part of brachial plexus, my dear students? It is the root of brachial plexus. Okay, my dear students. Now, so it is quite clear the root of brachial plexus is formed by the ventral rami of C5, C6, C7, C8 and T1. Now there are two branches from the root. This is DS and this is LTN. LTN. Can anybody tell me the full form of DS and LTN? Yes, Akshay. Very good. Yes. Now my question is, can anybody tell me? Akshay, Sadik, Surya, Prabha, Bharati, Sarthik, everyone. So we know that this is the root and the full form of DS. So what is the full form of DS? DS means dorsal scapular nerve. What is the full form of LTN? Long thoracic nerve. And long thoracic nerve is the Bell's nerve, which is giving innervation to which nerve? Which is giving innervation to which muscle? Serratus anterior muscle. Serratus anterior muscle. Okay. So that means dorsal scapular nerve and long thoracic nerve being the branch from the root of brachial plexus is the supraclavicular branch of brachial plexus. Now talking about the trunk. Trunk of brachial plexus. So this is the upper trunk, this is the middle trunk and this is the lower trunk. Okay, this is the lower trunk. Now, from the upper trunk, there is two branches. One is SS and that is NS. So, full form of SS is suprascapular nerve. Full form of NS is nerve to subclavius. Nerve to subclavius. Done. Now, this part of the brachial plexus is division of brachial plexus. Now, each of the trunk of brachial plexus will divide into how many division? Anterior and posterior division. Anterior and posterior division. Now, the anterior division, this is the A for anterior. This is also A for anterior. This is A for anterior. And these are P, P, P. So now in this diagram, you can see posterior division of upper, middle and lower trunk is forming which cords? It is forming which cord? Posterior cord of brachial plexus. You want to highlight it? I will highlight it. So this is the posterior division of upper, posterior division of middle, posterior division of lower trunk. This will lead to the formation of posterior cord of brachial plexus. And it is important for you to know the branches of each part of brachial plexus. Okay. Now, here I would like to firstly tell you about the branches of posterior cord of brachial plexus. Okay. Or let's go with the lateral cord, posterior cord and medial cord. Now, here you can see the anterior division. This is the anterior division of upper and the middle will join to form which cord? Will join to form the lateral cord of brachial plexus, will lead to the formation of lateral cord of brachial plexus. And the branches from the lateral cord of brachial plexus are, so we have got the branches, and this is lateral pectoral nerve, LPN. What is this nerve? This is musculocutaneous nerve. And this is lateral. This is lateral root of median nerve. This is lateral root of which nerve? MN. MN means median nerve. So the branches from lateral cord of brachial plexus, I just want to highlight in red color so that you will not get confused. So here all these branches are the branches from the lateral cord of brachial plexus. Okay, dear students. All these three branches, which I have highlighted in red color. So the mnemonic, if you remember, the mnemonic for the branches of lateral cord is medical leave to. If you remember, you want to go for a party, you want to invite some special person at your place, but your budget is low. So you will invite that special person at your place. You will clean the area. And when you want to invite, you want to apply for leave. So the branches of lateral cord of brachial plexus is ML2. M for musculocutaneous nerve. So how many branches, dear? Musculocutaneous nerve. The branches are musculocutaneous nerve, lateral pectoral nerve, and lateral root of median nerve. Now we will talk about the branches of posterior cord. So posterior cord. After that, you want to clean your place so that you can invite that special person at your place. So you want to clean your home. And when you clean your room, you found rats in the upper and lower cell. Rats. So here R for, this is radial nerve. This is AN for axillary nerve. This is upper self, US. This is upper rats, T for thoracodorsal nerve, upper self and lower self. Okay, I will write the full form. AN ka full form kya hoga? What is the full form of AN? Axillary nerve. AN full form is axillary nerve. What is the full form of US and LS? Upper subscapular and lower subscapular nerve. Upper subscapular and lower subscapular nerve. Okay. And R for radial nerve. Now we are left with which? Now we are left with only the medial cord. So I want to highlight the medial cord's branches in blue color. So this is the medial cord. Okay, this is the medial cord, and the branches of medial cord will be highlighted in blue color. So I'm just highlighting it blue color. And when you invited that special person at your place, you are telling to him or her, me for you, made for each other, me for you. So what are the branches? Again, we have got 4 branches. So we will have medial. This is medial root of which nerve? MN, median nerve. Made for M4 and then we will have medial pectoral nerve. So this nerve which you are seeing is the medial pectoral nerve. This nerve is MPN, medial pectoral nerve, and this is medial cutaneous nerve of arm, medial cutaneous nerve of forearm, and this is ulnar nerve, UN for ulnar nerve. This is UN for ulnar nerve. So this is how you are going to represent and know about the branches of different part of brachial plexus. I think everybody has done this in the previous time. Okay, dear? Yes, very good. Now 9 messages. Yes, so many of the students have given the answer and very good. They are knowing the identification. Now please write down quickly the similar thing. So we have done this. So quickly, my dear students, you are already knowing, write the structures. Branches from root of brachial plexus. The name of nerves are LTN, long thoracic nerve, Bell's nerve or long thoracic nerve. And the root value is C5, C6 and C7. The other one is DS, dorsal scapular nerve. What is the root value? C5. Now, branches from upper trunk of brachial plexus. Branches from upper trunk of brachial plexus. So, if I talk about the branches of upper trunk of brachial plexus, again it gives 2 branches, NS and SS. What is the full form of NS? Nerve to subclavius. And what is the root value? C5 and C6. What is the full form of SS? Suprascapular nerve. And what is the full form? Again, C5 and C6. Again, C5 and C6. Yes, yes, Akshay, absolutely right. Yes, Akshay, absolutely right. Minnie. Yes, all of you have given the right answers. Yes. Now we have done with this. Now we will move on with the branches of lateral cord of brachial plexus. So if I talk about the branches of lateral cord of brachial plexus, what is the mnemonic? ML2, medical leave 2, medical leave 2. So here M, here L, L. So here M stands for which nerve? Musculocutaneous nerve. Musculocutaneous nerve C5, C6 and C7. L stands for lateral pectoral nerve. C5, C6 and C7. Another L stands for lateral root of median nerve. Again C5, C6 and C7. C5, C6 and C7. Branches from lateral cord of brachial plexus. Done. Now branches from medial and posterior cord. Written branches from lateral cord, my dear students. ML2. Now firstly branches from posterior cord. What is the mnemonic? RATS. RATS in the upper self and in the lower self. RATS. Upper self and lower self. So here R for which nerve? Radial nerve. And what is the root value? C5, C6, C7, C8 and T1. A for which nerve? Axillary nerve. Root value C5, C6. T for thoracodorsal nerve. Root value C6, C7 and C8. Upper subscapular. So upper self, lower. So S for upper subscapular nerve. First S for upper subscapular nerve. First S for upper subscapular nerve. C5 and C6, and this is lower subscapular nerve, that is C5 and C6. Okay, these are the branches from the posterior cord of brachial plexus, upper subscapular and lower subscapular. Rats. Now coming to the branches of medial cord. What are the branches of medial cord? And what me for you means 4M and 1 U. So here M stands for medial pectoral nerve. The root value is C8 and T1. Medial cutaneous nerve of arm. Root value is again C8 and T1. Medial cutaneous nerve of forearm. C8 and T1. Medial root of median nerve. Again C8 and T1. And U for ulnar nerve. Here U stands for which nerve? U stands for ulnar nerve. U stands for ulnar nerve. And root value of ulnar nerve is C8 and T1. And in bracket you can write C7. And in bracket you can write C7. Okay, Harshvardhan, Chirag, Reshma. Okay, everyone, is it okay? Can we move on to the next, that is clinical anatomy? Yes, dear. Now we have to know about the clinical anatomy. Okay, Sonia, everyone. So let's now move on to the clinical anatomy. Okay, Sadik, Akshay, everyone. So let's move on to the clinical anatomy. So we have done with this. Now, clinical anatomy. So there is two kinds of injury. One is upper trunk brachial plex injury. The another is lower trunk brachial plex injury. So when I am talking about upper trunk brachial plex injury, the nerve roots which will be involved in this case is C5 and C6. Is C5 and C6. And the injury of upper trunk, where we have the injury of the root value C5 and C6, the common mode of injury is difficult vaginal delivery, and there is excessive increase in the angle between head and shoulder. So if there is excessive increase in angle between this head and shoulder, and then it can lead to upper trunk brachial plex injury. The other form of injury is someone is falling from a height. Somebody is falling from a height and landing on the ground. So there is excessive stretching of head, neck, and the shoulder, and the patient will have obstructive paralysis. The sign and symptoms in this case, you can see this is the position of arm and this is the position of forearm. So the arm is towards the body. It is medially rotated and adducted, and the forearm is pronated and extended. So you can see the sign and position. So in case of upper trunk brachial plex injury, that is called as obstructive paralysis. Obstructive paralysis. The arm of the baby or the man who is injured will be adducted and medially rotated. And the forearm, if I talk about forearm, forearm will be extended and pronated. Forearm will be extended and pronated. The arm will be adducted and medially rotated. Forearm will be extended and pronated. This is also called as waiter tip deformity or policeman tip deformity. It appears like someone is asking money from behind. So it is also called as waiter tip deformity or policeman tip deformity. Got it? Now, lower trunk brachial plexus, here the root values which was involved is C8 and T1. So site of injury will be lower trunk of brachial plex, mainly medial cord of brachial plex, and medial cutaneous nerve of arm and forearm is involved. And the reason is hyperabduction injury. What is the reason of injury? Hyperabduction injury, and it will lead to a case of Klumpke's paralysis. Here, T1 fibers are involved, and my dear students, T1 fibers are carrying sympathetic fibers along with it. That means here the patient will also have Horner syndrome. The mode of injury is hyperabduction. If someone is falling from a height and holding a branch of tree, and in this position there is hyperabduction of arm, this will lead to a case of undue hyperabduction of arm, leading to lower trunk brachial plexus injury. Other reasons are cervical rib and birth injury. Mainly the patient will have medial claw hand. So the patient, in case of lower trunk brachial plexus injury, that is leading to a case of Klumpke's paralysis. The patient will have claw hand medially in the medial 2 fingers, and the patient will have sign and symptoms of Horner syndrome. What is sign and symptoms? Partial ptosis, constriction of pupil, anhidrosis, absence of sweating, and anophthalmos. So these are the cases of lower trunk brachial plexus injury. Yes, you are right. Wait, so yes, everyone is right. Now, can we move on to some of the MCQs? So let's come with the MCQ. So this is an MCQ, which is a clinical MCQ. Not only clinical, it is also a image-based question clinical MCQ. So it's an image-based question clinical MCQ. So here a 23-year-old male person is evaluated after sustaining neck and shoulder injury. The nerve indicated by arrow. So you can see blue color small arrow is there. So you have to identify the nerve, and you have to also tell what will be the result of injury if this nerve is injured. So firstly, can anybody tell me which nerve is this? Identify the nerve. All of you identify the nerve with blue arrow in the brachial plexus. This is the image of brachial plexus. So all of you identify the nerve. No, dear. MPN, how it can be MPN? So see here, how you can identify, very easy. This is root. This is root. This is trunk. These are divisions and these are cords. So this is formed by joining these 3 divisions of 3 cords. So which cord is this? So which cord is this? So you can know the cord and you can know this nerve. So now you can know the cord and you can know this nerve. So now you can tell me which nerve should be this. So Veer, yes, Veer is telling, so some of the students, Veer, also Sonia and Surya are telling the right answer. It is the radial nerve. So basically, how you can identify this part is the posterior division of all the 3 trunks, and posterior division of all the 3 trunks will join to form the posterior cord of brachial plexus. So which cord is this? This is posterior cord. This is posterior cords. This is the posterior cord, and this is RN, radial nerve. This is AN, axillary nerve. This is US. This is LS, and this is LT. This is thoracodorsal nerve. So basically, rats in the upper and lower cell. So how we can identify the branches? By the mnemonic, rats in the upper and lower cell. Got confused with blue color word. Okay. No worries. Okay, no worries. You have to identify the arrow. So I will just mark this arrow marked now. Okay, this arrow marked. So which nerve is this? Radial nerve. And as this is a revision class, so I just want everybody to be knowing that radial nerve are giving innervation to all the muscles of posterior aspect of arm and forearm, which are extensors of the forearm. So what will be the right answer? So there will be loss of flexion, loss of abduction, extension, abduction, adduction, opposition. Absolutely correct. Absolutely correct. Everyone, Bharati, Akshay, Surya, everyone is correct. The correct answer will be loss of extension of hand. Yes, dear, the correct answer will be loss of extension of hand. Yes, doctor, everyone is absolutely correct. The correct answer is loss of extension of hand. Why? Because there is injury of radial nerve, and we know that radial nerve is giving innervation to the muscles of posterior aspect of arm, forearm, and the patient will have wrist drop. Yes, you are absolutely right. You are absolutely right. Now, question number second. Another question for the brachial plexus. A 12-year-old boy falls from a tree. He's climbing, but he catch hold of a branch of tree to save himself, and he swing by the right arm, jump to the ground. So he has landed in the emergency room with right hand clumsiness. The mode of injury is, means he is having hyperabduction injury when it is holding the tree. So which of the following structure is injured? Which of the following structure is injured? Let me check if the students are giving me the right answer or not. So Akshay has given and right answer. Joel, yes, Joel is also has given the right answer. Yes. Surya is also given the right answer. The right answer is brachial plex lower trunk injury. Yes, just now I told you if someone is falling from a height and to save himself or herself, they take catch hold of the branch of a tree. Such kind of injury is called as injury of brachial plex, lower trunk brachial plex. Absolutely correct answer. Yes, injury of lower trunk brachial plexus. Akshay, medial cord ulnar nerve. Yes. No, here there will be injury of lower trunk brachial plexus. Okay. Chirag, Harshvardhan, Reshma, everyone. Axillary nerve is, so basically the mode of injury will give you the right answer. Here the mode of injury is holding a branch of tree while he or she is climbing, and then the injury occurs. And here if you will see in the lower trunk brachial plex, what I have told you, that the injury will happen if someone is falling from height and holding a branch of tree. This is abduction injury. So basically the right answer will be lower trunk brachial plex injury. Okay. Now quickly revise all the nerves. Now we will quickly. Okay, dear. Yes. Now we will quickly. Surya, please explain last question. Yes, Surya. Yes, Surya. Surya, the mode of injury. To come to a right answer, we have to know the mode of injury. For lower trunk brachial plex injury, I told you the mode of injury is hyperabduction. And if you will see this diagram, in lower trunk brachial plex, I told you when someone is falling from a height and he or she save himself by holding a branch of tree, then here will be hyperabduction of arm or shoulder. And due to hyperabduction of arm and shoulder, the lower trunk brachial plex is injured. Also, the other reason is cervical rib. But here also mode of injury was that he or she wants to save himself by holding the tree, falling from a tree and catch hold of a branch of tree. Catch hold of a branch of tree. So, lower trunk brachial plex injury is the right answer. Is it okay, everyone? Is it okay, Surya? Okay, okay, dear. Okay, Surya. Now coming to ulnar nerve. So if I talk about ulnar nerve, the other name, so we will quickly recapitulate all the nerves. Okay, so if I talk about nerves, it is a very important topic, and slightly the nerves of upper limb is more difficult than the other areas because it is conceptual to understand. So when I'm talking about ulnar nerve is a branch of medial cord of brachial plexus, and ulnar nerve is giving innervation. Yes, you are right. Ulnar nerve is giving innervation to small muscles of hand. It is giving innervation to small muscles of the hand mainly, and two muscles in the forearm. So you have to know all the branches of ulnar nerve. It is called as musician nerve, and we have to know all the branches of ulnar nerve. So it is just giving innervation to two muscles of forearm, flexor carpi ulnaris and the flexor digitorum profundus medial part, and it is giving innervation to major muscles of the hand. So firstly, branches of ulnar nerve. Quickly, my dear students, write down branches of ulnar nerve. So branches of ulnar nerves are in forearm. In forearm, it innervates just two muscles, FCU, flexor carpi ulnaris, and FDP medial part. And what is the full form of FDP? Flexor digitorum profundus. That means two muscles are innervated by ulnar nerve. One is flexor carpi ulnaris, other one is flexor digitorum profundus medial part. Now talking about the innervations of the muscles of the hand. So when I am talking about the innervations of the muscles of hand, main muscles innervated by ulnar nerve is hypothenar muscles. Hypothenar muscles. And we know that in the hypothenar region, we have got three muscles: abductor digiti minimi, flexor digiti minimi, opponens digiti minimi. Opponens digiti minimi. Other muscles of the hand is adductor pollicis is also innervated. Also medial to lumbricals. Also all the palmar and dorsal introsei. All the palmar and dorsal introsei muscles. And also palmaris brevis muscle. Palmaris brevis muscle. Okay. So actually in this case, you can see number of muscles. Yes, Sadik, you are knowing 20 muscles in the hand. Yes, we have got 20 muscles in the hand. 3 in the thenar region. What is the name? Abductor pollicis brevis. Why pollicis? For the thumb. So mainly the thenar region muscle, flexor pollicis brevis, abductor pollicis brevis, opponens pollicis, these are supplied by median nerve. 3 in the hypothenar region, which I have already written: abductor digiti minimi, flexor digiti minimi, opponens digiti minimi. 2 lumbrical, medial one, not the lateral one, because lateral one will be supplied by median nerve. Adductor pollicis, all the palmar and dorsal introsei, that makes a total of 4 palmar and 4 dorsal introsei, and palmaris brevis, the muscle in the subcutaneous fat. So all these muscles, which makes the major content of the muscles of the hand, is supplied by ulnar nerve. So only ulnar nerve is called as Mugesian nerve. That is the reason ulnar nerve is called as Mugesian nerve. Now, so here you can see, if I talk about distribution, cutaneous distribution, the ulnar nerve is giving cutaneous distribution in medial 1.5, medial 1.5 of the finger. So you can see this is the image showing the cutaneous distribution of ulnar nerve. Okay, this notes will be given to you, so don't worry, you just understand. Wherever, if the soft copy is with you, try to write the notes. So you can see this is the medial 1.5 fingers and palm area. This is receiving cutaneous innervation by which nerve? Ulnar nerve. This is receiving cutaneous innervation by ulnar nerve. Done. Now, what will be happening if there is lesions of the ulnar nerve? So, if there is lesion of ulnar nerve, basically ulnar nerve is going medially to supply hypothenar muscle. So, when it traverses in the hand, it is traveling through a space that is called as Guyon's canal. What is that space called as? That space is called as Guyon's canal, and it will pass in the hypothenar eminences. I will show you the Guyon's canal area. Yes, Sadik, you are absolutely right. The patient will have partial claw hand. The claw hand will be only medial claw hand. The patient will have partial claw hand. That means only medial claw hand. So I just want everybody to understand what is Guyon's canal. So in this diagram, you can appreciate that this is flexor retinaculum of the hand. Okay, this structure is the flexor retinaculum of hand. This structure is the flexor retinaculum of hand, which is overlapped by, this structure is overlapped by the superficial slip of flexor retinaculum, and this structure is called as volar carpal ligament. So this structure is volar carpal ligament. This is called as volar carpal ligament. So the nerve which is passing beneath the volar carpal ligament is ulnar nerve, and on medial and lateral side it is bounded by which bone? Hook of Hammett and pisiform. That means the area. Now you can understand what is Guyon's canal. Guyon's canal is the space where ulnar nerve and ulnar artery passes. This space is located superficial to flexor retinaculum and deep to volar carpal ligament, and ulnar nerve passes between which two carpal bone? Pisiform and hook of Hammett. So this is the area where ulnar nerve can be compressed. Now ulnar nerve can also be compressed in other areas like, so it can be compressed between medial epicondyle and olecranon process. It can be compressed when it is passing between the flexor carpi ulnaris muscle. Yes, dear students. Yes, Akshay, you are right. It can be also compressed when it passes between the flexor carpi ulnaris muscle. So why I have written this? These are the common site where ulnar nerve entrapment or injury can happen. Now, that means when there is an injury, so if I'm talking about the injury, so when there is an injury to ulnar nerve will have so basically if the only deep branch is gone, basically all the muscles of the hand is paralyzed, and if the injury is at above level, sensory innervation is also gone. Now, I just want everybody to know about Foreman sign. Yes, dear? Foreman test. Very good, Akshay. So, to judge or to know the ulnar nerve injury, one of the tests can be done that is called as Foreman test for ulnar nerve. So, which test is done to see whether ulnar nerve is injured? That is Foreman test. So, Foreman test is done for ulnar nerve injury, and this is done to test the muscle. It is done to test the muscle. Which muscle? Adductor pollicis. Adductor pollicis. Now, I just want to demonstrate. Can you see this is a block? So this is a block or a block of paper. If you ask the patient of ulnar nerve injury to hold this block of paper or this block of structure between the thumb and index finger. So generally, we will hold it by adducting the thumb. So if I have to hold it, I will hold it by adducting the thumb, adduction of thumb. But adductor pollicis is paralyzed. Why adductor pollicis is paralyzed? Because ulnar nerve is injured. So for holding that structure, now it will be holded by flexing the thumb. And flexion of thumb is done by which muscle? Flexor pollicis longus. So that means Foreman test is positive in case of ulnar nerve injury. And the muscle which is tested is adductor pollicis muscle. The muscle which is tested is adductor pollicis muscle. Adductor pollicis muscle. Done, everyone? Now, can we solve MCQs, my dear students? My dear students, can we solve the MCQs? Yes. Yes. Oh, okay. Okay, dear. So let's solve the MCQs. Okay. A 19-year-old female. So all of you, please mark it right. Okay, yes, Foreman test, book test is for ulnar nerve. Yes, Foreman test, book test are for ulnar nerve. Now coming to answers are given B. Yes, so here there is injury and flattening. In this case, if I'm talking about this question, so here the injury is, if I talk about this question, the injury is in the right hand clumsiness and fifth finger and flattening of hypothenar muscles. So basically the nerve injured is ulnar nerve, and we know that ulnar nerve is passing close to hook of Hammett. Absolutely right. Close to hook of Hammett is absolutely right answer. Why not carpal tunnel? Why the answer is not correct carpal tunnel? Because in carpal tunnel, the nerve compressed is median nerve. Why not surgical neck of humerus? Because here the axillary nerve is compressed. Head of radius, the radial nerve is compressed, and coracobrachialis is BBC muscle, which is BBC means muscles of anterior arm, which is brachialis, biceps brachii, coracobrachialis, and these are innervated by musculocutaneous nerve. So the right answer is hook of Hammett. So the right answer is hook of Hammett. Absolutely correct. Absolutely correct, everyone. Everyone is absolutely correct, my dear students. Now, can anybody solve the next clinical MCQs? These are all clinical MCQs. A 53-year-old man complains of strange feeling in the right hand. Physical examination, there is loss of sensation over the fifth digit. Which of the following nerve is most likely injured? A. So the students are telling A, and A is absolutely right answer. Yes, the correct answer will be A. Okay, absolutely correct answer. Absolutely correct answer. Absolutely correct answer. Yes. Now, next nerve is the median nerve. Next nerve is the median nerve. So when I talk about median nerve, let's solve the next MCQs. Before that, let's quickly. So next important nerve is the median nerve. And we know that median nerve is having two roots. It is the thickest nerve of brachial plexus, and it is formed by two roots. Its medial root is C8 and T1. And what about its lateral root? Lateral root is C5 and C7. It is also called as labor nerve, and it is the thickest nerve of brachial plexus. Now, median nerve branches. So basically, median nerve will give major branches in the anterior part of forearm, and few muscles it will supply in the hand. So branches of median nerve in forearm. So in forearm, it supplies all the muscles. In forearm, it supplies all the muscles of front of forearm except two muscles, flexor carpi ulnaris and medial part of flexor digitorum profundus. So branches of median nerve in the forearm. So write down. In forearm, it gives innervation to pronator teres muscle, flexor carpi radialis muscle, palmaris longus muscle, flexor digitorum superficialis, deep muscles are flexor digitorum profundus lateral part. So what is the full form of FDP? I think everybody is knowing flexor digitorum profundus. We have already written pronator quadratus muscle and flexor pollicis longus and flexor FPL. Flexor pollicis longus. Now here pronator teres, flexor carpi radialis, palmaris longus, flexor digitorum profundus. These are directly supplied by median nerve. And if I talk about these three muscles, these are the muscles of deep compartment. These are the muscles of deeper aspect or deep compartment. These are the muscles of deeper aspect of deep compartment. This is supplied by deep branch of median nerve, and the name of that nerve is AIN. And what is the full form of AIN? Anterior introitious nerve. Anterior introitious nerve. So the full form of AIN is anterior introitious nerve. The full form of AIN is anterior introitious nerve. Deep branch of median nerve is called as anterior introitious nerve. Is called as anterior introitious nerve. Anterior introitious nerve. Now, it's also important for us to know the muscles supplied in the hand. So basically, written forearm, my dear students, in the hand, it is a revision part, and I think most of the students is knowing the answer. So median nerve branches in hand. So in hand, it supplies thenar muscles. Thenar muscles. And what is the name of thenar muscles? Abductor pollicis brevis, flexor pollicis brevis, opponens pollicis. If you want to write the full form, you can write it. Abductor pollicis brevis muscle, flexor pollicis brevis muscle, opponens pollicis. Thenar muscle. What about other? Lateral two lumbricals. Lateral two lumbricals. Lateral two lumbricals. That is first and second. That is first and second. Lateral two lumbricals. Absolutely correct, dear. Yes, lateral two lumbricals, first and second. First and second. So all these muscles of the hand is supplied by the median nerve. Median nerve. Now we have done with this. I also want you to show the cutaneous distribution. So when we are talking about cutaneous distribution, it will give innervation on the dorsum of the hand. Which part? Lateral part of the dorsum and the palmar aspect. Lateral part of the dorsum and palmar aspect. Which part of the dorsum? Only the nail buds. So which part of the dorsum? Only the nail buds. So this is median nerve is supplying nail buds. Median nerve is supplying nail buds. Median nerve is supplying the nail buds, that is lateral 3.5. Lateral 3.5 of the nail buds. So it's a dorsum aspect, lateral 3.5 of the nail buds. And palmar aspect, we are giving lateral 3.5 of the palm. Cutaneous distribution, what will be the lesion? So my dear students, see, let me show you few the clinical aspects. So basically, we can see most of the muscles of forearm and lateral part of FDP and FPL. That means the flexors of the thumb and that of index finger is all supplied by the median nerve. So if you tell the patient to clasp their hand like this, clasp or make a fist. If you tell them to make a fist like this or clasp their hands, their lateral fingers, index fingers is straight, and this condition is called as Osner clasping test, pointing index finger. So this will lead to inability of flexing the thumb. So there will the patient will have inability to flex the thumb, inability to flex the index finger because lateral part of FDP is paralyzed. Here, pen test is positive. Here, the patient will have pen test positive. Why? Because we know the thenar muscles are supplied by which nerve? Thenar muscles are supplied by, if I talk about thenar muscles, these are supplied by which nerve? Thenar muscles are supplied by median nerve and abductor pollicis brevis. As you can see, if there is a pen and you want to touch the pen, so you have to abduct the thumb. So that abduction of the thumb will be done by which muscle? Abductor pollicis brevis. Here abductor pollicis brevis is paralyzed. So pen test is positive. Pen test is positive. Lesion of median nerve. Basically all the muscles of thenar region will be paralyzed, and also abductor pollicis brevis, flexor pollicis brevis, opponents, and but adductor pollicis will not be paralyzed. Why? Adductor pollicis is supplied by which nerve? Ulnar nerve. So the patient will have adduction of thumb and there will be flattening of this area, and this condition is called as ape thumb deformity. This condition is called as ape thumb deformity. Very good. So here the injury. Now, where will be the injury? So we know that median nerve is passing beneath flexor retinaculum. If I talk about median nerve, it is passing in the carpal tunnel, and carpal tunnel is a space which lies beneath flexor retinaculum. So here you can see this is flexor retinaculum. This is called as flexor retinaculum. What is this? This is called as flexor retinaculum, FR. This is called as transverse carpal ligament, or this is called as flexor retinaculum. The nerve which is passing beneath flexor retinaculum is the median nerve, and this will be compressed in this area, leading to median nerve compression carpal tunnel syndrome. Now, here you can see this is the cut section. In this diagram, you can see this structure which I have highlighted in green color is the flexor retinaculum. It's the flexor retinaculum, and beneath this we have got the median nerve. So this will, in case of carpal tunnel syndrome, median nerve is compressed. The patient will have, already the compression is there. If you tap on the anterior aspect of the wrist like this, what will happen? Tenal test. This is called as tenal test, and the pain and paresthesia will be increased due to increased compression of median nerve. Tenal test is positive, and if you tell the patient to make a dorsiflex like this, means ulta namaskar, then what will happen? More pressure on the flexor retinaculum. So this is called as Fallon test. So the patient will have Fallon test positive. The patient will have tenal test positive. The patient will have atrophy of thenar muscles. These are signs and symptoms of carpal tunnel syndrome due to median nerve compression. Also, we have seen the median nerve passes in between the pronator teres muscle. So there will be a case of pronator teres syndrome. So there will be pain and paresthesia in the lateral aspect. Yes. Can we go to MCQs? Yes. Let's come with the MCQs. Okay. Now, a 45-year-old female present to your office with numbness of right palm. After taking a detailed history and physical examination, there is median nerve lesion. So can you tell me the course of median nerve, or median nerve is related to which muscle? Median nerve is related to which muscle? Median nerve. We are talking about median nerve. C. Okay, students are telling C. C, flexor superficialis and flexor digitorum profundus. Absolutely correct answer. Absolutely correct answer. Yes, all of you are right. This is correct answer. Now, the median nerve does not innervate which of the following muscle? Median nerve, yes, you all are right. Everyone is right. Now, next question is median nerve does not innervate which of the following muscles? Adductor pollicis, absolutely right answer. Absolutely right answer. Absolutely right. A patient wants to make a fist, but he is not making the complete fist. Here, the index and the middle finger is partially extended. Can you tell me the injury of the nerve? So yes, this is Benedict sign, and the injury of nerve is median nerve. Absolutely right. Yes, this is Benedict sign, and the injury of nerve is median nerve. Absolutely correct. Yes, this is Benedict signs, median nerve injury. Now, the last nerve, which we will quickly recapitulate, is the radial nerve. Now, radial nerve is the largest. Radial nerve is the largest branch of brachial plexus. Its root value is C5, C6, C7, C8, and T1. And it is a continuation of posterior cord of brachial plexus. Now, basically, if I talk about radial nerve, it gives innervation to all the muscles. It gives innervation to all the muscles of posterior aspect of arm, posterior aspect of forearm. So we can write the name of these muscles. So if I'm talking of the branches of radial nerve, it is innervating. So in axilla and arm, it is innervating following muscles. So it is innervating triceps brachii muscle. That means it is innervating long head, medial head, and lateral head of triceps brachii muscle. It also innervates brachialis muscle. It also innervates brachialis muscle. So these muscles will be supplied by radial nerve directly in the arm. Now I want you to tell all the extensor group of muscle, that is the muscle in the posterior part of the forearm, is getting innervation from radial nerve. So write down branches in the back of forearm, muscles in the back of forearm. So they are innervated. So what are the name of these muscles? ECRL and brachioradialis. What is this? ECRL and brachioradialis. Full form brachioradialis and extensor carpi radialis longus. So these two muscles are directly supplied by radial nerve. So if I talk about these two muscles, brachioradialis and extensor carpi radialis, they are directly supplied by radial nerve. Rest all muscle. What is the name? ECRB. Extensor pollicis longus, extensor pollicis brevis, abductor pollicis brevis, extensor indicis, extensor digiti minimi, extensor digitorum, extensor carpi ulnaris, supinator. Okay, all these muscles are supplied by deep branch of radial nerve. All these are supplied by deep branch of radial nerve. Okay. And what is the name of deep branch of radial nerve? PIN. What is the full form? Posterior introitious nerve. Posterior introitious nerve. The full form is posterior introitious nerve. And one more muscle supplied, anconius. And actually anconius is supplied by branch from radial nerve. So that means most of the muscles are supplied by deep branch of radial nerve. And what is the name of deep branch of radial nerve? PIN, posterior introitious nerve. So extensor carpi radialis brevis, extensor pollicis longus, extensor pollicis brevis, abductor pollicis brevis, extensor indicis, I for index finger, DM for D for digitorum, EDM for digiti minimi for the little finger, ECU for extensor carpi ulnaris and supinator. All these muscles are supplied by deep branch of radial nerve. Yes, absolutely right. Now let's see this image. In this image, you can see cutaneous branches of radial nerve. So if I talk about cutaneous branches of radial nerve, the cutaneous distribution they are giving cutaneous distribution on the posterior aspect of arm, posterior lateral aspect of lower forearm, posterior cutaneous nerve of forearm, and the dorsum of hand. So dorsum of the hand on the lateral 3.5. Dorsum of the hand in the lateral 3.5, except the nail buds, not the nail buds. Why not the nail buds? Because nail buds are supplied by median nerve. Why not nail buds? Because nail buds are supplied by median nerve. So posterior cutaneous nerve of arm, posterior cutaneous nerve of forearm, lower lateral cutaneous nerve of arm, and dorsum of the hand except the nail buds. Now, what will be the lesions? So let's quickly revise the lesions. So if we are talking about the injuries which happens in the axilla, that means all the muscles of extensor group will be paralyzed, triceps will be paralyzed, and the patient will have wrist drop. And all sensory losses. So the patient will have sensory losses and all the muscles which is supplied by radial nerve is paralyzed. If the lesion occurs in the axilla, when the lesion will occurring in the axilla? So when is the lesion occurring in the axilla? The lesion occurs in the axilla when the person is ambulated, means the person is having fracture of fibula and tibia or lower limb. So yes, cop-up splints used. Yes, dear. So in that case, what happens? There will be fracture. They want to walk, so they will use crutches. The next injury is in the spiral groove. If somebody has gone for party for the Saturday night, and yes, absolutely correct to everyone, crutch palsy and Saturday night palsy, there will be compression in the radial groove, and due to compression in the radial groove, again all the muscles is paralyzed, which is supplied by radial nerve, and this will called as Saturday night pulse. But in this case, The injury is in the middle of the shaft of humerus, means somewhere here. Means spiral groove is in the arm, somewhere here. But a part of triceps muscle is not paralyzed fully. That means triceps is not paralyzed fully. It is not paralyzed as whole, means it is partially paralyzed. So that means elbow extension is not impaired, but wrist drop will be there. That means elbow extension is not fully gone. Why? Because triceps is not fully paralyzed. Because if I talk about spiral groove, it is somewhere in the middle of the humerus. Okay. Next type of injury is, now before that, injury to deep branch. When there is injury to deep branch, PIN, so you know that PIN is the deep branch of radial nerve. So it will paralyze all the deep muscles, extensor group. We know the name: supinator, extensor carpi radialis, brevis, extensor pollicis longus, abductor pollicis, EI, extensor digiti. So all these muscles are paralyzed. There will be no sensory loss. And also, if I talk about effect on the wrist, the patient will have the patient cannot have full wrist drop because brachioradialis and extensor carpi radialis longus is still working. Yes, in case of very good Akshay, in case of PIN injury, there will be loss of finger extension, there will be loss of finger extension and thumb extension. The patient will have loss of finger extension and thumb extension, not complete wrist drop, because brachioradialis extensor carpi radialis longus is supplied directly by radial nerve, not by deep branch. So only there will be loss of thumb extension and finger extension, no sensory loss. The radial head is related with the radial nerve, radial head, and in case of radial head subluxation, also radial nerve is injured. Now I want, so if triceps is paralyzed, injury is in the axilla. If brachioradialis is paralyzed with triceps, normal, injury in radial group. If both are paralyzed, if both triceps and brachioradialis are paralyzed, that means injury level is beyond the level of lateral epicondyle. Okay. Now let's come up with the MCQs. Everyone, let's come up with the MCQs. So please solve the MCQ. A patient presents to the emergency department with weak wrist extension. On physical examination, sensation to the arm is intact. So the affected nerve not likely to be injured in this case. No, was most likely, not no, was most likely to be injured in this case. And location. So injury, weak wrist extension. So radial nerve is injured. Can you tell me the location? Yes, Sadik is absolutely right. Head of radius. Yes, G. Everyone is right. That is the location will be head of radius. Yes, location will be head of radius, and that is absolutely right. That is absolutely right. Yes, D is the right answer. Head of radius. Head of radius is right. Next. A 25-year-old male fractured his tibia in motor vehicle accident. Leg is fixed in cast. He requires crutches to ambulate. Difficulty in wrist extension. Injury of which nerve is seen in this case? Here, easy one. Radial nerve, absolutely right answer. Yes, dear, all of you are absolutely correct. Radial nerve is the right answer. Now, a 30-year-old man underwent excision of right radial head. Following the surgery, the patient developed inability to extend the fingers, thumb. He is not having any sensory deficit. So can you tell me which is the nerve injured? Only finger extension and thumb extension is gone. PIN, yes, PIN, injury to posterior introosseous nerve. Absolutely right. Absolutely right. Injury to posterior introosseous nerve. Absolutely correct. PIN is absolutely right. Now, match the following. Please give me the most correct answer. Match the following. which is correctly paired? Which is most correct pairing in this MCQ? Chirag, Harsvardhan, Sai. No, not C, not C. No, dear, not correct. Not correct. More chance. Exactly correct answer. Exactly correct answer. Which is the most correct one? No, B is partially correct. No, till now I didn't get the right answer. Should I explain? No one has given the right answer. Akshay, A. And who is this? Janu. Okay. And Josie. Yeah, now I am getting the right answer. A. Joel. Yes, A is the right answer. Most correct. Yes, now I got the right answer. Absolutely correct. So we know that flexor pollicis longus is the deep. This is the correct. Flexor pollicis longus is the deep muscle. Flexor pollicis longus is the deep muscle of the forearm and its innervation is via anterior interosseous nerve. So absolutely correct. This is the most correct answer. Now, flexor digitorum profundus is supplied by A and it is partially correct. Why? Because FDP is supplied by both median nerve and that of ulnar nerve. Which branch of median nerve? AIN, anterior interosseous nerve. So that is medial part is supplied by ulnar nerve and lateral part. So it is partially correct. Extensor carpi radialis is directly supplied by radial nerve. Brachioradialis is also directly supplied by radial nerve. And abductor pollicis longus is supplied by deep branch that is posterior interosseous nerve. So the correct answer is flexor pollicis longus, which is supplied by deep branch of median nerve. So everyone, okay? Everyone understood? Can we go to the next one? Everyone understood? Can we go to the next MCQ? Yes, yes, dear. Radial nerve innervates which muscles? Okay, okay, understood. Very good. Now, radial nerve innervates muscles in the extensor compartment forearm, and it is also innervating one of actually okay, give me the answer. Then I will tell you. Absolutely correct. Brachioradialis. Actually, brachioradialis is the muscle of extensor compartment, but it is also having the action of flexion and supination, pronation. So it's a muscle which is unique, being a muscle of the extensor compartment, but it is also having action of supination, pronation from mid-prone position. So brachioradialis is the right answer. Now, arteries, which is anastomosing around surgical neck of humerus. So what is the name of the artery which is anastomosing around surgical neck of humerus? And it is a branch from which part of axillary artery? No, no. What is the name of artery which wind around axillary artery? So don't worry, I will explain. So see here. This is surgical neck of humerus. And we know that surgical neck of humerus is related to axillary nerve and the arteries which is anastomosing is posterior and anterior circumflex humeral artery. Posterior and anterior circumflex humeral arteries are the branch of third part of axillary artery. So basically, yes, they are the branch of very good, those who have given. These are the branches of third part of axillary artery. So C is the right answer. Yes, this is the branch from the third part of axillary artery. So C is the right answer. Very good. Very good. It is the right answer is C. Very good. Third part of axillary artery. Now, bicipital aponeurosis is covering which structure in the cubital fossa? Manasi, Sai, Chirag, Harshvardhan, Akshay. Bicipital. So bicipital aponeurosis is located in cubital fossa. So it is covering one artery and one nerve. It is covering one artery and one nerve. Let me show you. See here. This structure which you are seeing is the bicipital aponeurosis. What is bicipital aponeurosis? It is a medial extension from biceps tendon. So bicipital aponeurosis. If I talk about bicipital aponeurosis, so if I talk about bicipital aponeurosis, it is an extension from biceps tendon. So it is an extension from biceps tendon and it is covering two structures. It is covering medial nerve and brachial artery. So it is covering which two structures? Medial nerve and brachial artery. So what will be the right answer here? Brachial artery. What will be the right answer? Brachial artery. Brachial artery. Yes, absolutely correct. Now coming to the next MCQ, a clinical MCQ. A 56-year-old man comes to emergency department because of wrist pain. While walking his dog, he fall forward to the ground and landed on outstretched hand. There was swelling on the dorsum of the hand and tenderness. This is the clinical important point. There is point of tenderness in which area? Anatomical snuff box. There is tenderness in anatomical snuff box. X-ray has been shown below. Can you tell me the complications? So see here, this part, this is R for radius and this is U for ulna. And you can see this bone is fractured. This bone is fractured. Okay, so this is lateral. This is lateral and this is medial. So this bone is fractured and you can tell me what will be the complication in the patient. What is the right answer? Yes, avascular necrosis. Avascular necrosis. Absolutely correct. The fractured bone is, what is the fractured bone? This anatomical snuff box will contain, C looks too pretty, scaphoid. So there is fracture of scaphoid bone. And when this fracture of scaphoid bone is there, it is having a peculiar kind of blood supply from dorsal aspect. So the scaphoid bone will have complication like avascular necrosis, and in long lasting cases the patient can have also arthritic condition. So avascular necrosis is the right answer. Here you can see this is the dorsal scaphoid branch, and in case of fractured scaphoid bone, the blood supply scaphoid bone is affected and it leads to the condition of avascular necrosis. Now we will go to lower limb. Before going into the lower limb, quick revision. Quickly, I want you to revise the muscles and their action. Yes, absolutely right, everyone. Now let's see the name of the muscles and the action. So write down muscles, name of the muscles and the action. So shoulder joint. If I talk about shoulder joint, so many muscles are there which is performing major action. So let's talk about flexion. Flexion of shoulder joint is done by pectoralis, major muscle, clavicular part. Flexion is also done by anterior part of deltoid muscle. Extension of shoulder joint is done by latissimus dorsi and posterior part of deltoid muscle. Abduction of shoulder joint. Abduction of shoulder joint is done by abduction is done by 0 to 15 degree. Is done by supraspinatus muscle. 15 degrees to 90 degree. Abduction is done by deltoid muscle middle fiber. And greater than 90 degree overhead abduction is done by trapezius and serratus anterior muscle. Adduction is done by coracobrachialis muscle and latissimus dorsi muscle. Lateral rotation is done by teres minor and infraspinatus muscle. Medial rotation is done by teres major and subscapularis muscle. Yes, Surya, teres major is causing medial rotation. And of the arm. And teres minor is causing lateral rotation. Okay, done. Now coming to the lower limb part. So, okay, now, so basically we will go with few other important topics. So everyone, can we go with femoral triangle? So in lower limb, we have to know about the movements of hip joint. We have to know about the injuries of knee joint. We have to know about femoral triangle, adductor region and nerves. Okay. Okay. So, anyone wants a break or is it okay? Do you want a break or is it okay? Should I continue? Okay, very good. So femoral triangle boundaries. So you can see the boundary. So inguinal ligament is forming the base. Sartorius muscle is forming the lateral boundary and adductor longus is forming the medial boundary. Okay, so we have got inguinal ligament forming the base. Sartorius muscle is forming lateral boundary. Adductor longus is forming medial boundary. This triangular dotted area is the femoral triangle depressed area in the upper part of thigh anteriorly. Now, muscles of the floor of femoral triangle is mnemonic is AP. So, A for adductor longus muscle, P for pectineus, another P for psoas major, and laterally we have got the iliacus muscle. This is showing the muscles forming the floor of femoral triangle. This is showing you the muscles of femoral triangle. AP. Okay, dear. Now, in femoral triangle, you have to know the content separately for the roof and content inside. So, mainly in femoral triangle, you can see blue color is for femoral vein. Red color is for artery and yellow color is for femoral nerves. It's for the femoral nerves. Okay, it's for the femoral nerve. Other than this, we will also have femoral branch of genitofemoral nerve as the content, and medial most we have got femoral canal which is containing deep inguinal lymph node. So basically medial most content is the deep inguinal lymph node. So for femoral triangle, I want everybody to write the content. So firstly, I want you to write the roof. So what is roof? Roof we will have skin and superficial fascia. Roof will have skin and superficial fascia. And in the superficial fascia, we will have so many structures. So in the superficial fascia, we will have so many structures, and superficial fascia is containing superficial branches of femoral artery and adjoining veins. Okay, it will also contain So this is showing superficial branches of femoral artery and adjoining vein. And it will also contain other content. It will contain superficial inguinal lymph nodes. Superficial inguinal lymph nodes. It will contain great saphenous vein. It will contain ilioinguinal nerve. It will contain femoral branch of genitofemoral nerve. So these are contents of roof. These are contents of the roof. We have to separately know the content which is lying inside. These are the contents of the roof, but we have to separately know the content lying inside. So now let's write the content of the femoral triangle. Now we are writing exact content of femoral triangle. So exact content of femoral triangle can be memorized by a mnemonic navel from lateral to medial. From lateral to medial. So ये सारे content कहाँ से हैं? These are all content. So main contents can be memorized by navel, NAVEL. Why? Because L for lymphatics and it is the medial most content. So here N for nerve. N for nerve. So which is the important nerve? Femoral nerve. Femoral nerve. And also a branch to pectineal. So also a branch from femoral nerve, that is branch to pectineal. So which two nerves mainly is the femoral nerve and branch to pectineus? This is the most important content. Then we will have, so actually so many other contents are also, we will A for femoral artery. So not only femoral artery, we have got 6 branches of femoral artery as the content. How many? We have got 6 branches. So please write down the name of the 6 branches. 6 branches. So here 3 superficial branches. So we will have 3 superficial branches. So we will have 3 superficial branches. That is, we will have 3 superficial branches. Superficial circumflex iliac artery. Superficial external pudendal. Superficial epigastric. Superficial epigastric artery. Superficial epigastric artery. Deep external pudendal artery. Muscular branches. Profunda femoris artery. Profunda femoris artery. Very important. So these 3 branches are deep branch and these 3 branches are superficial branch. These 3 branches are superficial branch of femoral artery. The third is vein. Which vein? Femoral vein. No need to write the name of tributaries. So corresponding to the arteries, there will be vein tributaries. Other than that, we will have E for, what does E stands for? E is nothing. E is empty space. E is empty space. So which is the medial most content? That means L. L means lymphatics. Which lymphatics? Deep inguinal lymph node. And deep inguinal lymph node is also called as lymph node of Rosenmuller. It is also called as lymph node of Rosenmuller or Cloquet. It is also called as lymph node of Rosenmuller or Cloquet. Lymph node of Rosenmuller or Cloquet. Yes, I'm coming to that. Don't worry. We have got, yes, you are right. More contents are there. So we will have deep inguinal lymph node. We will have lymph node of Cloquet and Rosenmuller. We will have lymph node of Cloquet and Rosenmuller. And the other contents are few more nerves, that is lateral cutaneous nerve of thigh. Lateral cutaneous nerve of thigh. And femoral branch of genitofemoral nerve. Femoral branch of GTN. What is the full form of GTN? Genitofemoral nerve. Femoral branch of genitofemoral nerve. So all these are the contents of femoral triangle. All these are the contents of femoral triangle. Femoral branch of GTN means genitofemoral nerve. Femoral branch of genitofemoral nerve. Femoral branch of GTN means genitofemoral nerve. Done, my dear students? Yes, coming to femoral sheath. Yes, don't worry. So if I talk about, so you can see this is showing you the branches. In this image, you can see the 6 branches. In this image, you can see the 6 branches. So we will have the branches of the femoral artery, superficial circumflex iliac, superficial epigastric, superficial external pudendal, deep external pudendal, profunda femoris artery, and muscular branches. So these 6 branches are the content of femoral triangle. Now femoral, so this is an image which is showing you the important structure. So we can see here the vein, we can see here the artery, and we can see here the nerves. Now, coming to the femoral sheath. So basically, if I talk about femoral sheath, you already know what is femoral sheath. Femoral sheath is covering proximal upper part of femoral vessels. It is covering proximal part of femoral vessels. It is covering proximal upper part of femoral vessels. So in this diagram, you can see the sheath and its content. So a quick revision, everyone. Okay, Akshay, yes. A quick revision of femoral sheath. So when I'm talking about femoral sheath, it is covering the upper proximal part of femoral vessels. And an important point for you to note down is the nerve. The femoral nerve is lying outside the femoral sheath. The femoral nerve is lying outside the femoral sheath. So what you can see, the femoral nerve is lying outside and it is divided into 3 compartments. What is the medial compartment containing? The medial compartment of femoral sheath is also called femoral canal, and it contains the deep inguinal lymph nodes of Cloquet. It contains deep inguinal lymph node of Cloquet. It contains deep inguinal lymph node of Cloquet. Intermediate compartment is containing femoral vein, and femoral artery is the content of lateral compartment along with the femoral branch of GFN. What is GFN? Genitofemoral nerve. Genitofemoral nerve. Okay. So all these are the contents of femoral sheath in the medial, intermediate, and lateral compartment. So now, as I told you, femoral canal. What is femoral canal? Femoral canal is containing deep inguinal lymph node, and it is medial compartment of femoral sheath. It is medial compartment of femoral sheath. It is medial compartment of femoral sheath. Got it? Okay. It is medial compartment of femoral sheath. So all of you can write about femoral canal. Now, I just want in case of herniation can occur via femoral ring and canal, and this condition is called as femoral herniation. This condition is called as femoral herniation. Femoral hernia. You can see this. This is the case of femoral hernia. Here, the herniation of femoral content. Femoral hernia is more common in females, and herniation will occur due to weakness of femoral ring and femoral canal. Now coming to the next one. So let's talk about the next one, adductor canal. So what do you understand by adductor canal? Adductor canal is the medial or the middle 1/3 of the, it is located in middle 1/3 of the thigh, and adductor canal is actually, what you have to know about adductor canal is boundaries, content, and also the subsartorial nerve plexus, which is lying beneath the sartorius muscle. So here boundaries, you can see adductor canal is located in the middle 1/3 of the thigh. It is bounded medially by which muscle? Sartorius muscle. Posteriorly by adductor longus and adductor brevis, and anterolaterally by vastus medialis. The important contents are, it is also important for you to note down that femoral nerve is not the content of adductor canal. Femoral vessels along with saphenous nerve, nerve to vastus medialis, and also obturator nerves are the content. Also beneath the sartorius muscle, you can see there is nerves, and this will form subsartorial nerve plexus. So please write down, how is the subsartorial nerve plex form? So plex means multiple nerves. So there are 3 nerves which will form together subsartorial nerve plexus. How many nerves are there? There are 3 nerves which will together form subsartorial nerve plexus, and the name of that nerves are saphenous nerve. The name of that nerve is medial cutaneous nerve of thigh. Medial cutaneous nerve of thigh, and anterior division of obturator nerve. Anterior division of obturator nerve. Okay. Now, my dear students, I have already written the content of adductor canal. Now, other than that, these are the important content. Other than that, it also contains, you can continue here. It also contains obturator nerves, and it contains descending genicular artery. It also contains descending genicular artery. Okay, so content is already written in the image. In that content, you can add on obturator nerve and also descending genicular arteries. Also, you can note down descending genicular arteries. So done, we have done with femoral triangle. We have done with adductor canal. Now, here you can see the saphenous nerve and femoral arteries passing through the adductor canal in this cadaveric image. Now, coming to the next topic, Trendelenburg sign. So, if you remember in the previous part, I have already told you which nerve injury causes Trendelenburg sign. Trendelenburg sign positive is in which nerve injury? Anybody remembers? Superior gluteal nerve injury. Superior gluteal nerve injury leads to positive Trendelenburg sign. And it leads to the paralysis of which muscle? Yes, I got an answer from, yes, Akshay. Medial, yes, paralysis of the muscles is gluteus, medius, and minimus. It causes paralysis of gluteus, medius, and minimus. And these two muscles, which is gluteus, medius, and minimus, these two muscles are abductors of thigh. They are abductors of thigh. They are abductors of thigh. They are abductors. Now, my next clinical aspect is when we tell that this is an unhappy triad of knee joint. So, when there are 3 ligaments of knee joint which is injured together, we give it a name that is called as unhappy triad of knee joint. So, which 3 nerves are injured together? ACL, medial meniscus, and medial collateral ligament. Medial collateral ligament is also called as tibial collateral ligament. So it happens in football players or rugby players. If there is a strong injury, if there is a strong hit on the knee joint, there will be injury of these three structures: ACL, anterior cruciate ligament, medial meniscus, medial collateral ligament, and this condition is called as the, yes, very good, Mani Akshay. This condition is called as unhappy triad of knee joint or terrible triad of knee joint. Unhappy or terrible triad of knee joint. Now, this condition is called as housemaid knee. Housemaid knee. And in the case of housemaid knee, there is inflammation of subcutaneous prepatellar bursa. There is inflammation of subcutaneous prepatellar bursa. So this condition is called as housemaid knee, important for your examination. If there is inflammation of subcutaneous prepatellar bursa, this condition is called as housemaid knee. This condition is called as clergyman knee. This is called as clergyman knee. And in this condition, there is inflammation of subcutaneous infrapatellar bursa. Infrapatellar bursa. This is inflammation of subcutaneous infrapatellar bursa. Okay, after when I am just going to finish the lower limb, yes, Akshay, absolutely right, namaz position. So after this important lower limb, important topics, I will give you a break of 10-15 minutes. Is it okay, everyone? I will cover up the upper limb, lower limb, and then I will give you a break. Okay. Now, pecs unserine bursitis, inflammation of bursa related to common insertion of sartorius semitendinosus and gracilis muscle on proximal medial aspect of tibia. On proximal medial aspect of tibia. So insertion of sartorius semitendinosus gracilis muscle on the proximal medial aspect of tibia will lead to pecs unserine bursitis. Got it? Now, movements of hip joint. So I just want everybody to write like it's a multi-axial joint like shoulder joint. So please note down the muscle causing movements of the hip joint. So we have got following muscles. So please write down. Flexion. So flexion of hip is done by sartorius muscle, psoas major iliacus. Okay, I'm writing the major muscles. Also by pectineus muscle. Extension. Also by quadriceps femoris muscle. Extension is done by hamstring muscle. Plus gluteus maximus muscle. Adduction of hip is done by adductor longus, adductor brevis, adductor magnus, pectineus, gracilis. Abduction of hip is done by gluteus medius and minimus, and tensor fascia lata. Medial rotation is done by anterior fibers of gluteus medius and minimus, and lateral rotation is done by lateral rotation is done by small muscle covered by gluteus maximus like obturator internus, obturator externus, piriformis muscle, gemellus superior, gemellus inferior, quadratus femoris. Quadratus femoris. Done? Okay. Now, so if I talk about nerves, nerves are very easy. Yes, dear. Nerves are very easy in case of lower limb. So everybody must be knowing femoral nerve is the nerve of anterior compartment of thigh. It is the nerve of anterior compartment of thigh. It is a nerve of anterior compartment of thigh. And what is the root value? So femoral nerve root value is, it is formed by, so it is giving innervation. So that means it is, so this flow chart is enough to know that innervation. So femoral nerve is innervating all the muscles of anterior compartment of thigh like sartorius, quadriceps femoris muscle, that is vastus medialis, lateralis, vastus intermedius, rectus femoris, and it gives cutaneous branches like intermediate medial cutaneous nerve of thigh and saphenous nerve. The root value is femoral nerve. Root value is, it is formed by dorsal division, ventral rami of L2, L3 and L4. L2, L3 and L4. Dorsal division, ventral rami of L2, L3 and L4. Okay, my dear students. If I talk about obturator nerve is the nerve of medial compartment of thigh. And its root value is anterior division of L2, L3 and L4. And it is giving innervation to adductor longus, adductor magnus, pectineus, obturator internus, externus also, obturator externals. And it is giving innervation to medial most part of the thigh. So this flow chart is showing you all the innervation area of obturator nerve, the nerve of medial compartment of thigh. Next comes sciatic nerve, which is the nerve of posterior compartment of thigh. Posterior compartment of thigh. Nerve of posterior compartment of thigh. It is a nerve of posterior compartment of thigh. And it is giving innervation to all the hamstring muscles. So it gives innervation to hamstring muscles. Okay. Which it gives innervation to hamstring. It gives innervation to hamstring muscle. Okay? Now, what are the hamstring muscle? The muscles of back of thigh are hamstring muscle. The muscles of back of thigh, semitendinosus, semimembranosus, long head of biceps, and hamstring part of the adductor magnus. Only the short head of the biceps femoris is innervated by which nerve? Common peroneal part of sciatic nerve. It innervates. So basically, sciatic nerve is having two parts. One is common peroneal part and the other is tibial part. So tibial part of sciatic nerve is giving innervation to the muscles of posterior compartment of thigh. Which part? Tibial part. And common peroneal part is innervating the short head of biceps femoris. Now, if I talk about tibial nerve, it is the nerve of posterior leg muscles, posterior leg compartment. So that means all the muscles of posterior leg is, or posterior leg compartment is innervated by tibial nerve. What will be the root value? The root value of tibial nerve is, it is formed by ventral division, ventral rami of L4, L5, S1, S2 and S3. L4, L5, S1, S2 and S3. L4, L5, S1, S2 and S3. Common peroneal nerve. So we know that sciatic nerve. So basically, if I'm talking about sciatic nerve, its root value is also ventral rami of L4, L5, S1, S2 and S3. It is also having the root value L4, L5, S1, S2 and S3. Sciatic nerve is having two parts. One is the tibial nerve, which will go in the posterior part of the leg, and common peroneal nerve is the other part which will wind around. See here, common peroneal nerve. If you will see this common peroneal nerve, the common peroneal part of the sciatic nerve, actually the division of common peroneal nerve and tibial nerve, part of sciatic nerve takes place in the superior aspect of popliteal fossa. So it will divide around. So it will wind around the neck of fibula and will divide into two nerves. What is it? Deep peroneal nerve and superficial peroneal nerve. Okay, common peroneal nerve is formed by dorsal division, ventral rami of L4, L5, S1, S2. And here it will divide into two nerves. One is deep peroneal nerve, another is superficial peroneal nerve. So superficial peroneal nerve innervates muscles of lateral leg compartment, and deep peroneal nerve supplies muscles of anterior leg compartment. So all the muscles of the leg in the anterior compartment will be supplied by deep peroneal nerve, and all the muscles of lateral compartment, that is peroneus longus brevis, will be supplied by superficial peroneal nerve. Now, it's also important that you should pay attention to the cutaneous innervation. So see here, common peroneal nerve, cutaneous innervation, saphenous nerve. What is saphenous nerve? It is a branch of femoral nerve which will give innervation in the medial side of the leg. And you can see this is deep peroneal nerve, which is giving cutaneous innervation in the adjacent area of great toe and adjacent toe. Okay. And this is the innervation. So the tibial nerve will go in the sole, dividing into the plantar nerves. And here we have got SPN, superficial peroneal nerve. SU means sural nerve. SA means saphenous nerve. So I just want you to go through these images. Why? Because image-based question can come and you have to identify the cutaneous distribution of the nerves of lower limb. Basically, nerves of lower limb is very easy. The nerve of anterior compartment of thigh is femoral nerve. The nerve of medial compartment of thigh is obturator nerve. The nerve which is going in the posterior hamstring part is the sciatic nerve. Sciatic nerve divides into two nerves, tibial, common peroneal nerve. Tibial nerve will go in the posterior part of the leg compartment, will supply all the muscles of posterior leg compartment. Tibialis posterior, flexor hallucis longus, flexor digitorum longus, popliteus, gastrocnemius, soleus, plantaris. And common peroneal nerve will divide into two nerves. The superficial will go in the lateral compartment of the leg, giving innervation to peroneus longus or peroneus brevis. If I am talking about the deep peroneal nerve, that will go in the anterior compartment and it will give innervation to all the muscles of anterior leg, that is tibialis anterior, extensor hallucis longus, extensor digitorum longus and peroneus tertius. Okay, so only these things you have to know, and I will give you, actually I want everybody to just go through this boxes. Why? Because this has also been asked in examination. So the structures passing through greater sciatic foramen, the structures passing through lesser sciatic foramen, and so we have got Many structures passing through greater sciatic foramen, piriformis, superior gluteal nerves and vessels, inferior gluteal nerves and vessels, nerve to quadratus femoris, sciatic nerve, posterior cutaneous nerve. We have got just one structure which is passing through lesser sciatic foramen. That is only exiting through lesser sciatic foramen. That is the tendon of obturator internus. We have got PIN. PIN means pin structure. P for pudendal nerve, I for internal pudendal vessels, and N for nerve to obturator internus. These are three structures which will pass from greater sciatic foramen and then come to lesser sciatic foramen. All these boxes is asked in examination. Why I want everybody to go through these boxes? Because I'm concentrating for the examination. I know this is a quick recapitulation of important topics. So you have to go through these boxes, which is telling you all the structure which is passing through greater sciatic foramen, lesser sciatic foramen, passing through lesser sciatic foramen, and then reaching in the lesser sciatic foramen. Now, the last topic of this lower limb, you have to also know about the structures in the intercondylar area of tibia. What is this area? This is the intercondylar area of tibia. So the structure, so I would like to mark the structure by number from anterior to posterior. So from anterior to posterior, the structures are anterior end of medial meniscus, anterior cruciate ligament, anterior end of lateral meniscus, posterior end of lateral meniscus, posterior end of medial meniscus, and the posterior most compartment is posterior cruciate ligament. So these are the three structures. These are the six structures. So this is medial meniscus anterior end. This is anterior cruciate ligament. This is anterior end of lateral meniscus. This is posterior end of lateral meniscus. This is posterior end of medial meniscus and posterior cruciate ligaments. So these six structures, from first to sixth structure, is passing or located in the intercondylar area of tibia as you move from anterior to posterior. So it is very important for you to know this sequence. Okay, my dear students. So all of you, we have finished most important topic and slightly detailed I have given. Now I will concentrate for the rest part, the most important topic for your examination. So we will quickly finish that also. Like I want you to give a break of 15 minutes, 10 to 15 minutes. Is it okay? Everyone. Okay, so break of 10 to 15 minutes. So take 15 minutes break. Okay, dear. 15 minutes break. Okay. So be present for the session online, only 1.5 hours more. So just 90 minutes more, I will take the session. I will complete the entire important part. Don't worry, this session is very, very important. So many things has to be explained. So after 15 minutes, I want everybody to be live. All the best. Let's meet after 15 minutes. start? Okay, my dear students, can we start? Everyone is back. So I know your time is very, very precious now. Yeah, okay, Akshay. Okay, Akshay. So yes, don't worry about neuroanatomy. Akshay is telling neuroanatomy बहुत difficult लगता है. Actually, now we are concentrating on the most important part, which will be targeted more for the MCQ. So I will just brief you. Okay, don't worry about that. Because now the time is that we have to focus on the most important part, which is sure shot going to be asked. So whichever topic today I'm taking, whichever topic I'm taking today will be asked in examination. So more chance hai ki isme se question aaye. So few questions can come from these topics. So please go through these topics. So now this is the, in the thorax, one of an important topic is intercostal space. So you can see this is the rib above and there is a rib below. So in between this ribs above and below, we have got muscles. So we have got external intercostal muscles. We have got internal intercostal muscle and we have got innermost intercostal muscles. So we have got three layers of the muscle as you proceed from outside to inside: external intercostal muscle, internal intercostal muscle, and innermost intercostal muscle. We have got external intercostal muscle, internal intercostal muscle, and innermost intercostal muscle. And we have got neurovascular plane. So basically we have got VAN. So what is this VAN? That is the nerve. We have got vein, artery and nerve. So we have got vein, artery and nerve, and intercostal vein is there. There is intercostal artery and there is intercostal nerve. So basically the location of intercostal vein, artery and nerve is located and passing in between the ribs. So basically the plane in which the vein, artery and nerve is passing is the plane between the internal intercostal muscle and innermost intercostal muscle. So the plane will be in between internal and innermost intercostal muscle. Now, intercostal muscle names I have written. These are all list of muscle which is called as intercostal muscle: external, internal, and transverse thoracic. So transverse thoracic group of muscle is actually made of three muscles: innermost intercostal muscle, subcostalis, and sternocostalis. All these notes will be given to you. Okay. Now, for your examination, in the previous year of examination, so many times the question has been asked as the list of inspiratory muscle. So this is the list of all inspiratory muscle. So basically diaphragm and external intercostal muscles are primary muscles of inspiration. They are primary muscles of inspiration. They are primary muscles of inspiration. They are primary muscles of inspiration. So external intercostal muscle and diaphragm are primary muscles of inspiration. And rest all muscles which you can see in this list are accessory muscles of inspiration. Rest all these muscles are accessory muscles of inspiration. I want everybody to note down the name and you should by heart the name of these muscles. Why I will tell you. Now, we have got few muscles in the neck: sternocleidomastoid, scalenus group of muscle, levator, costarum, serratus posterior superior. So this has been asked number of times. Actually, pay attention that serratus posterior superior is an accessory muscle of inspiration, but serratus posterior inferior. Serratus posterior inferior is the muscle of expiration. We have got levator, scapulae, trapezius, rhomboides, pectoralis, serratus anterior. So the muscles of upper limb, the muscles of head and neck region, all these are the muscles of accessory muscle of inspiration. Serratus posterior superior is an inspiratory muscle, but serratus posterior inferior is an expiratory muscle. If I talk about the process of expiration, it is a passive process. Not a muscle is involved. So no muscle is involved. It is the elastic recoil of the alveoli which takes place, and this leads to expiration. So no muscle is involved in this process, and the muscle which is active in expiration is the quadratus lumborum, internal intercostal muscle, and transverse thoracic. I have already told you about transverse thoracic. What do you mean by transverse thoracic muscle? The muscle which is consist of internal intercostal intimi muscle, sternocostalis, and subcostalis muscle. Now, This is again important for FMG, that you should be knowing which nerve are typical intercostal nerve and which nerve are atypical intercostal nerve. So we have got third, fourth, fifth, sixth as the typical intercostal nerve, and we have got first, second, 8, 9, 10, 11, all are atypical. So when I'm using the word atypical, what do you mean by typical? So when I use the word typical, it means, when I use the word typical, it means that these nerves are confined in their intercostal space. These nerves are confined in their intercostal space, so they are called typical. If I talk about atypical, first, second, 8, 9, all are atypical because these are not only confined in their intercostal space, but they will roam around or wander. They will give innervation to other areas also. So they are called atypical. Now, intercostal arteries are very important. So we have got posterior intercostal arteries. So we have got posterior intercostal arteries. So we have got posterior intercostal arteries and we have got anterior intercostal arteries. So this is posterior intercostal arteries and we have got anterior intercostal artery. Now, posterior intercostal arteries are the branch of, so if I talk about first and second, if I talk about first and second posterior intercostal arteries, posterior intercostal arteries. So first and second are branch of superior intercostal arteries, and they are subsequently branch of costocervical trunk. And third to 11th posterior intercostal arteries are directly branch of DTA. What do you mean by DTA? Descending thoracic aorta. What is the full form of DTA? Descending thoracic aorta. Anterior intercostal arteries are only present in 9 spaces. First to 6 are directly the branch of internal thoracic artery, and internal thoracic artery is the branch of first part of subclavian artery. Now, 7th, 8th and 9th anterior intercostal arteries. 7th, 8th and 9th anterior intercostal arteries are branch of musculophrenic artery. They are branch of musculophrenic arteries. Got it? Intercostal arteries, we have got anterior and posterior intercostal arteries. If I talk about posterior intercostal arteries, first and second are the branch of superior intercostal artery, which is the branch of costocervical trunk. If I'm talking about anterior intercostal arteries, we have got these arteries only in the upper 9 spaces, in which first, second, third, fourth, fifth, sixth are the branches of internal thoracic artery, that is first part of subclavian artery. If I'm talking about 7th, 8th and 9th, they are branch of musculophrenic artery. Okay, dear. Now, this is an image where you can see posterior intercostal arteries are directly the branch of DTA. And first, second are the branches of superior intercostal arteries, which is the branch of costocervical trunk. Now, coming to the next topic, that is intercostal vein. So now we will talk about intercostal vein. So just see this image. Actually, intercostal vein, you just understand. If you want, I will write it. Everyone, my dear students, Thomas, Mickey, Akshay, Joel, everyone. So I just want to explain you by this image. If it is okay, if you understood, it is okay. Otherwise, I will write. Okay. Because, okay, Akshay and Surya. So just see here. So in this is showing you intercostal veins. So actually intercostal veins, if I talk about, we have to pay attention to posterior intercostal vein. So in this image, we can see drainage of which veins? Posterior intercostal vein. So for understanding the drainage of posterior intercostal vein, just pay attention to these images. So all of you, if you will see this image, you can understand the drainage of posterior intercostal veins. So see here. Here we have got, so this is the first posterior intercostal vein. Okay, this is the first posterior intercostal vein of right side, and this is the first intercostal vein of the left side. This is right side and this is left side. Okay, so here we have got first posterior intercostal vein of the right side, and here we have got first posterior intercostal vein of the left side. So in this diagram, what you can appreciate, the right side first posterior intercostal vein will drain into brachiocephalic vein, and left side will also drain into brachiocephalic vein. So what you can say, both right and left side. All of you just see the image. Both right and left side posterior intercostal vein will drain into respective brachiocephalic vein. And here you can see second, third and fourth. If you will see second, third and fourth are forming superior intercostal vein on right and left side. In left side, it is draining into which vein? Can you see? It is draining into left brachiocephalic vein. So in this diagram, you can see in left side, the left superior intercostal vein drains into brachiocephalic vein. And in the right side, it is draining into azygous vein. Now, 5th, 6th, 7th, 8th, 9th, 10th, 11th, all will also drain into azygous vein in the right side. But 5th, 6th, 7th, 8th in the left side will drain into accessory hemiazygous vein. 9th, 10th, 11th will be draining into hemiazygous vein. So, why there is difference in the drainage of posterior intercostal vein on the right side and left side? रीजन क्या है? रीजन ये है, जो अजाइगस वेन है उसका मिरर इमेज लेफ्ट साइड में होता है. अपर पार्ट को हम एसेसरी हेमी अजाइगस वेन बोलते हैं और लोअर पार्ट के मिरर इमेज को हम हेमी अजाइगस वेन बोलते हैं. सो हियर व्हाट यू कैन अप्रिशिएट, the first posterior intercostal vein of the right side and the first posterior intercostal vein of the left side will drain into respective brachiocephalic vein. Second, third and fourth will form superior intercostal vein. The right will drain into azygous vein and the left will drain into left brachiocephalic vein. 5th, 6th, 7th, 8th in the left side will drain into accessory hemiazygous. 9th, 10th, 11th will drain into hemiazygous. In the right side, all will drain into azygous vein. So have you understood, everyone? Everyone, Harshvardhan, Joel, everyone, Thomas, Mickey, Matthew, everyone understood? Can we move on to the next topic? Okay, very good. Done. So here I will just write drainage of posterior intercostal vein is important. It's important. It is important. So you can just go through this and you can understand why it is important. Now coming to mediastinum. So how many parts are there in the mediastinum? We have, so what do you understand by mediastinum? It is the space which is lying between the mediastinal pleura. So here I want to draw an imaginary line. So here I want to draw an imaginary line. See here. This is an imaginary line which is passing through anteriorly through angle of Lewis and posteriorly through T4 and T5 thoracic vertebra. So basically what you can see, an imaginary line is passing through anteriorly through angle of Lewis and posteriorly through T4 and T5 thoracic vertebra. The space which is lying above this line is dividing the mediastinum. So this part of mediastinum is called as superior mediastinum. This is what superior mediastinum. The space below where the pericardium heart and its great vessel lies is called as middle mediastinum. This part is called as middle mediastinum. Anterior to it, we have got the anterior mediastinum, and posterior to it, we have got the posterior mediastinum. So that means we have to know about all the mediastinum content. So you can see overall the mediastinum is divided into 4 parts. Okay, superior mediastinum and inferior mediastinum. The inferior mediastinum is further divided into 3 parts: anterior, middle and posterior mediastinum. Now we have to know about the contents of anterior, middle and posterior mediastinum. So all of you quickly write down the contents. All of you quickly write down the contents of superior, middle and posterior mediastinum. It is very important for your examination. So contents are superior mediastinum contents: arteries, arch of aorta and its branches, arch of aorta and its branches. So you already know the branches of arch of aorta. Subclavian, left subclavian artery, what is it? Left subclavian artery, common carotid artery, left common carotid artery, and brachiocephalic trunk. So what are those? So we have got arteries, arch of aorta and its branches, left subclavian artery, left common carotid artery, and brachiocephalic trunk. The next is veins. So important veins are upper part of superior vena cava, superior intercostal vein, left superior intercostal vein, and brachiocephalic veins. Yes, superior intercostal vein, that is of left side, and brachiocephalic veins. Very good. If you have attended my previous session, then you must be knowing this. What about nerves? So quickly write down the nerves. The nerves is phrenic nerve, sympathetic trunks, vagus nerve of both right and left side, and only left recurrent laryngeal nerve. Only left recurrent laryngeal nerve. We have got thymus gland also as the content. We have got thoracic duct also as the content, esophagus and trachea. We have got the muscles. Which muscles, dear? The muscles are sternothyroid, sternohyoid, longus colli. Content of superior mediastinum. Content are arch of aorta and its branches, left subclavian artery, left common carotid artery, brachiocephalic trunk, superior part of upper part of superior vena cava, superior intercostal veins, and brachiocephalic veins, nerves, thymus gland, thoracic duct. Now coming to the content of anterior mediastinum. So you only can tell me the content. So if I talk about anterior mediastinum, it contains sternopericardial ligament. Sternopericardial ligament. It contains sternopericardial ligament. It contains lower part of thymus gland. It contains lower part of thymus gland. Mediastinal branch of internal thoracic artery. ITA, what is the full form? Internal thoracic artery. And mediastinal lymph node. And mediastinal lymph nodes. So the important contents will be of the anterior mediastinum, sternopericardial ligament, the lower part of the thymus gland, the mediastinal branch of internal thoracic artery, and mediastinal lymph node. Absolutely correct, dear. Content of middle mediastinum, very easy. The heart and its great vessels. This is middle mediastinum is heart and great vessels, nerves, trachea, which part? Principal bronchus. So basically for the middle mediastinum and lower part of superior vena cava, lower part. So basically all the structures which is related to the heart, pulmonary trunk, pulmonary veins, lower part of superior vena cava, ascending aorta, all these structures along with the bifurcation of trachea into principal bronchus, heart, great vessels covering, that is pericardium. Okay. Now content of posterior mediastinum. Now write down content of posterior mediastinum. Content of posterior mediastinum. So content of posterior mediastinum is following. The content of posterior mediastinum is it contains thoracic duct. It contains vagus nerves. It contains descending thoracic aorta, DTA, descending thoracic aorta. It contains esophagus. It contains azygous venous system. That means all the veins, that is. It contains posterior mediastinal lymph node. Thoracic duct and sympathetic trunks. Trunks containing splanchnic nerves and all, containing splanchnic nerves. So basically it is containing the sympathetic trunks, also containing the splanchnic nerves, containing posterior mediastinal lymph node, vagus nerve, thoracic duct, descending thoracic aorta, azygous vein. All these are contents of posterior mediastinum. All these are the contents of posterior mediastinum. Done, bache? All these are the contents of posterior mediastinum. Now coming to coronary arteries. How many coronary arteries are there? We have got right and left coronary arteries. Okay, Akshay. So how many coronary arteries? We have got left coronary artery and we have got right coronary artery. Now, so what is asked in examination is the branches. So right coronary artery, important branches are right marginal, posterior descending artery, which is also called as posterior interventricular artery. It gives branches to SA node and AV node. If I talk about left coronary artery, the most important branches, left anterior descending, left circumflex, left marginal and diagonal arteries. The origin of coronary arteries are very important. So actually, if I talk about coronary arteries, they are arising from the aortic sinus. So right coronary artery will arise from right anterior aortic sinus. It will arise from anterior aortic sinus, and left coronary artery will arise from left posterior aortic sinus. So write down about coronary arteries and then we will talk about triangle of Koch. So write down the heading coronary arteries. So we have got right coronary artery. So right coronary artery. Hello, yeah. Right coronary arteries. So right coronary artery arises from, it originates from right coronary artery is originating from anterior aortic sinus. It originates from anterior aortic sinus and its branches are, so its branches are, important branches is posterior interventricular artery, which is also called as the dominant artery of heart, The other is right coronary arteries gives it gives blood supply to SA node and AV node. So SA node will give arterial supply in 60% cases, AV node will give arterial supplies in 80% of the cases. It also gives right marginal artery. What are the important branches of left coronary artery? Now, if I talk about left coronary artery, the left coronary artery originates from left posterior aortic sinus. Left posterior aortic sinus. It originates from left posterior aortic sinus and its important branches are LAD artery. What is it? LAD. What is the full form of LAD artery? Left anterior descending circumflex artery. Left marginal artery and diagonal artery. And diagonal arteries. And that of diagonal arteries. Okay? Now let's see the another image in which you have to know about location. So basically, I would also like to tell you about the triangle of Koch. What is triangle of Koch? Triangle of Koch is located in the interior. So in this diagram, you can appreciate the boundaries of triangle of Koch. In this diagram, you can appreciate the boundaries of triangle of Koch. The boundaries of triangle of Koch. So if we talk about the boundaries, what you can see, it is bounded superiorly by tendon of Toledo. So superiorly, what is the boundary? Tendon of Toledo. Tricuspid valve is anteriorly and postero-inferiorly is the opening of coronary sinus. Can anybody tell me what lies inside triangle of Koch? So triangle of Koch lies, what structures lies inside? What lies inside? So it contains, what does it contains? It contains AV node. So AV node is located in triangle of Koch. AV node is located in triangle of Koch. This is the location of AV node. This is the location of AV node. Okay? Done? Now, next is to know the planes. So actually in abdomen, so many planes has been asked. Okay, planes. So you have to know the level of transpyloric plane, intertubercular plane, subcostal plane and supracristal planes. So actually in this diagram only you can see subcostal plane L3 vertebral level, intertubercular plane L5, transpyloric plane L1 and the supracristal plane is at the level of L4. So write down abdominal planes, important abdominal planes level. So the first one is transpyloric plane. So the level of transpyloric plane is L1 lumbar vertebra. Tip of, it corresponds to tip of 9th costal cartilage. Fundus of gallbladder, it corresponds to the level of fundus of gallbladder GB. Then we have got subcostal plane. Subcostal plane is corresponding to the level of L3 lumbar vertebra. We have got supracristal plane corresponding to highest point of iliac crest. Highest point of iliac crest corresponding to the level of L4 lumbar vertebra. And transtubercular or intertubercular plane. Transtubercular or intertubercular plane. So if I talk about transtubercular and intertubercular plane, this plane corresponds to the level of L5 lumbar vertebra. This plane corresponds to the level of L5 lumbar vertebra. This plane corresponds to the level of L5 lumbar vertebra. Okay. Okay, dear. This is corresponding to L5. Now we will move with few more important topics of abdomen, pelvis. So here, I just want everybody, it's already in the notes, you have to go through the difference of the inguinal hernia and femoral hernia. So everybody is knowing, if I'm talking about femoral hernia, the herniation is occurring via weakness of femoral ring, that is the upper part or the base of femoral canal. And where is the femoral canal located? In the medial part of femoral shape. Now, why femoral canal herniation is more common in females? Because they have got a wider pelvis. The next is above the level of inguinal ligament, we have got two modes hernia, that is called inguinal hernia. So if it is a case of indirect inguinal hernia, the herniation will occur via deep inguinal ring and inguinal canal. And if the herniation is direct inguinal herniation, then the herniation will occur through inguinal triangle, which is also called as Hazelback triangle. Actually, the anatomical structure which is forming a boundary between indirect and direct hernia, inguinal hernia, is inferior epigastric vessel. So indirect hernia will be lateral to inferior epigastric vessel and direct hernia will be medial to inferior epigastric vessel. The same thing has been written here. So you can see the relation with the inferior epigastric vessel. The location of sac is lateral to inferior epigastric in indirect and the location of sac is medial. Also, the pathway of protrusion is through Hazelback triangle in direct and it's through inguinal canal in indirect. So I want you to know the difference between direct and indirect inguinal hernia. Okay. Now, it's also important for your examination that you should be knowing about which of the following structure is having only covering of peritoneum and one level. So that all structure is called as retroperitoneal structure. So in our body, we have got few organs and few structures which is having just one covering of peritoneum. It is not entirely covered by the peritoneum, and such structures are called as retroperitoneal structures. So retroperitoneal structures can be memorized by the mnemonic SAD-Pucker. It can be memorized by the mnemonic SAD-Pucker. SADPUCKER. Here S stands for suprarenal gland, A for aorta, inferior vena cava, D for duodenum, P for the pancreas, U for the ureter, C for colon, K for kidney, E for esophagus, and R for rectum. So just by heart the retroperitoneal structures. Now I also want, so if you enlarge derivatives, it's important that you should be knowing about derivatives of ventral mesogastrium. So derivatives of ventral mesogastrium, what are the derivatives? So it is actually, these are lesser omentum. These are lesser omentum. These are right and left triangular ligaments with triangular ligaments, coronary ligaments, falciform ligament. Now, there is a mnemonic also for memorizing this, that is lesser fact. That is lesser fact. Mnemonic kya hai? Lesser fact. To memorize the structures derived from ventral mesogastrium. These are all embryology questions and the derivatives of dorsal. Now write down derivatives of dorsal mesogastrium. Derivatives of dorsal mesogastrium are gastrosplenic ligament, gastrophrenic ligament, linorenal ligament, greater omentum. Okay. 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 Very good. Now, relations of stomach. Next important topic is relations of the stomach. So for relation of the stomach, you can refer this image in which anteriorly stomach is just related to anterior abdominal wall, left costal margin, diaphragm, and left lobe of the liver. Superiorly, the liver is related to left dome of the diaphragm, And posterior relation of the stomach is called as stomach bed. Now, why it is called as stomach bed? Posterior relation is called as stomach bed because stomach is resting over many viscera, and it has been asked so many times in the examination. So it is resting over lesser sac, pancreas, transverse colon, transverse mesocolon, kidney, suprarenal gland, spleen, and splenic artery. Okay. So very important. Now, arterial supply of the stomach. When I am talking about arterial supply of the stomach, it is very, very important that you should be knowing about important arteries. So the important arteries are right gastric arteries. So arterial supply is right gastric artery. The arterial supply is left gastric artery, short gastric arteries, right and left gastroepiploic artery. Right and left gastroepiploic artery. So if you want to know, left gastroepiploic artery is a branch of splenic artery. Right is branch of gastroduodenal artery. Short gastric artery is again the branch of splenic artery. Left gastric artery is directly the branch of CT, ciliate trunk, and right gastric artery is the branch from the hepatic artery, proper hepatic artery, sometimes also from common hepatic artery. Okay, so these are 5 arteries in which most important arterial supply is via left gastric artery. So these are 5 source of arterial supply. In this, most important source of arterial supply is via left gastric artery, which is directly the branch of celiac trunk. Now, ligaments, just know the ligaments name. So we have got gastrosplenic ligament, we have got gastrocolic ligament, and phrenicocholic ligament. In this diagram, you can see phrenicocholic ligament is indirectly giving support to the spleen, and also so basically why I'm telling about, so basically we are now concerned about the ligaments of the spleen. So most important topic for the spleen is only the ligaments which is asked. So we have got 3 ligaments. So see here, these are the 3 important ligaments in concerning with the spleen. So basically the content has been asked in examination. So what does gastrosplenic ligament contains? Gastrosplenic ligament contains short gastric arteries. Short gastric arteries. Phrenicocholic ligament is giving indirect support to the spleen. And one more important one is, this is the one, this is the second, and one more important, which is linorenal ligament. Is linorenal ligament, which is containing, linorenal ligament is containing tail of pancreas and splenic artery. Okay. So these are the 3 important. Gastrocolic ligament is more related with the stomach support. So gastrocolic ligament is more related with the stomach support. If I'm talking about the spleen, we have got 3 important ligament: gastrosplenic, linorenal, and phrenicocholic ligament. Basically, phrenicocholic ligament is indirectly giving support to the lower inferior aspect of the spleen. It is preventing the descent of the spleen. Now, relation of the kidneys anterior. So this diagram is showing you anterior relation of kidney. So actually, we have got right kidney and left kidney. I want everybody, yes dear. Okay, I want everybody to pay attention to the anterior relation of the kidney. So anteriorly, the kidney is related with suprarenal areas. And in the right side, we have got hepatic and duodenum area. Colic and jejunal area is common to right and left anterior side. In case of left side, we have got 3 other viscera related, that is pancreas, gastric area, and splenic areas. Jejunum, ileum, and suprarenal areas are common. So everybody should know about anterior relation of both right and left kidney. Same way, this diagram is showing you posterior relation of kidney. So if I talk about posterior relations of the kidney, it is related with diaphragm. It is related with psoas major muscle, quadratus lumborum, and transverse abdominis muscle. Now, in the right side, it is just related with 12th rib. but in the left side, it is related with both 12th and 11th ribs. So this is important for you to understand that in case of posterior relation of the kidney, actually liver lies in the right side. So right kidney will be slightly lower than the left. So right will be related with just 12th rib, but left will be related with 11th and 12th rib, and it is also related with nerves and vessels. Posteriorly, it is also related with nerves and vessels. What is that? That is subcostal nerves and vessels. It is related with subcostal nerves and vessels. It is related with iliohypogastric nerves, and it is related with ilioinguinal nerve. It is related with iliohypogastric and ilioinguinal nerves. Okay. Now, mesentery. So when I'm talking about mesentery, what is mesentery containing? Mesentery contains coils of ileum and jejunum. It contains coils of ileum and jejunum. It is a fold of peritoneum. What is asked in examination is structured crossed by mesentery. So basically, this is very, very important for you to know all the structures which is crossed by root of mesentery. So the structures crossed is all of the following 6 structures. Horizontal part of duodenum, abdominal aorta, the great vessels, the abdominal aorta, the inferior vena cava, right gonadal vessels, right ureter, and right psoas major. Also note down the attachment. So basically, if I talk about the mesentery is attached from duodenojejunal flexors to that of ileocolic junctions. Ileocecal junction. So this is the attachment of mesentery. So for examination, you have to know about the attachment and you have to know about the structures crossed by mesentery. Okay. Now for the abdomen, I would like quickly to recapitulate the branches. So everyone should be knowing branches of abdominal aorta. So what are the branches? The branches of abdominal aorta is very, very important for you. So here you can see the important branches are inferior phrenic artery, celiac artery, celiac trunk, superior mesenteric artery, inferior mesenteric artery, 4 pairs of lumbar artery, renal artery, gonadal artery, right and left common iliac arteries. We have also got middle sacral arteries, and we have also got middle suprarenal arteries. So basically, I have marked 11 branches of abdominal aorta. So these are all the branches of abdominal aorta, which is directly arising from the great artery, that is abdominal aorta. Okay, now branches of celiac trunk. Branches of celiac trunk. So the branches of celiac trunk directly is splenic artery, left gastric artery, and common hepatic artery. Common hepatic artery gives gastroduodenal artery, which further divides into 2 arteries, right gastroepiploic artery and superior pancreatico-duodenal artery. Superior pancreatico-duodenal artery. Okay? Superior pancreatico-duodenal artery. So branches of celiac trunk done. Superior mesenteric branches. So superior mesenteric artery branches. So let's talk about branches of superior mesenteric artery. So branches of superior mesenteric arteries are middle colic, right colic, ileocolic, jejunal and ileal branches, and one more which is not mentioned here, that is inferior pancreatico-duodenal artery. Inferior pancreatico-duodenal artery. Inferior pancreatico-duodenal artery. Inferior pancreatico-duodenal artery. Now, branches of IMA. IMA means inferior mesenteric artery branches. So inferior mesenteric artery is giving 3 branches. Superior rectal artery, sigmoidal artery, left colic artery. Sigmoidal arteries, sigmoidal artery and left colic artery. Left colic artery. Absolutely correct, dear Sonia. Everyone, Thomas, Mickey, Akshay, Joel, everyone, absolutely correct. So done with the branches now. Okay, anterior relation of right ureter is all. So actually, okay, so this is actually ureter is posteriorly related with the common iliac artery bifurcation. So here this diagram is showing you anterior relations of right and left ureters. So yes, you can see that gonadal vessels of both the side and mesentery is related to the right ureter and sigmoidal mesocolon to the left ureter. So you have to go through with the anterior relation of right and left ureters. And this diagram is showing you the posterior relation. So in this diagram, you can see the posterior relations of ureter. So what is the posterior relation, my dear students? Psoas major muscle and bifurcation of the common iliac artery. So bifurcation of common iliac artery. Common iliac arteries. So CCA bifurcate. Common iliac artery bifurcates. Common iliac artery bifurcates into external iliac and internal iliac artery. Now coming to head and neck. In head and neck part, important arteries, branches, I want you to know. So everybody, I think I have already done this. Just a quick revision. What are the branches of external carotid artery? The mnemonic for the branches of external carotid artery is some anatomists like freaking out poor medical students. Okay. Thomas, Akshay, Joel, everyone. What is the branches? 8 branches. There is 8 branches. And what is the mnemonic, my dear students? Some anatomists like freaking out poor medical students, that is superior temporal, maxillary, posterior auricular, occipital, lingual, superior thyroid, ascending pharyngeal arteries. Is it okay? Okay. Now, branches of maxillary artery. So maxillary artery is divided into 3 parts. Why? We know that maxillary artery branches. Okay, Akshay. So maxillary artery is divided into 3 branches by which muscle? Lateral pterygoid muscle. So all of you can know the branches of maxillary artery. So from the first part, so maxillary artery has got from first part, we have got 5 branches. From the second part, muscular branches. And from the third part, 6 branches. 6 branches. Now see this image. So this is maxillary artery first part. So from the first part, if you will see, this is the first part. And from the first part, if I talk about maxillary artery, it gives 6 branches. It gives 5 branches. So these are the 5 branches. And the mnemonic for this branches is MAID, Mada or Damia. So the mnemonic is Mada or Damia. So what are this? Anterior tympanic, middle meningeal artery, accessory meningeal, inferior alveolus, deep auricular. So all these 5 branches is the branches from the first part of maxillary artery. Now coming to the branches from the second part. If I talk about the second part, it is mainly giving, the second part is mainly giving muscular branch to pterygoid muscle, temporal, buccinator, masseter. So all these are muscular branches. Second part, all branches are muscular. Third part. Now coming to the third part. If I talk about the third part is giving 6 branches. Third part is giving 6 branches. That is pig pass. What is the mnemonic? Pig pass. The branches are pharyngeal, infraorbitals, greater palatine artery from descending palatine, posterior superior alveolar, sphenopalatine and artery to pterygoid canal. So how many branches? 6 branches. So in this diagram, all the branches. So here from the first part, we have got 5 branches. From the first part, we have got 5 branches. We have got 4 muscular branches from the second part and 6 branches from the third part. Okay, pick, pass, matha, all these mnemonic. Branches of facial artery, we have got 4 cervical and we have got 4 facial branches of facial artery. Giving to the upper lower lips, that is superior, inferior labile, giving to the nose, lateral nasal angular, giving to the tonsil, mandibular, submental and also glandular branches. Now, actually, I want you to solve one MCQs. Actually, if you remember the class of artery, I told you middle meningeal artery is injured. Middle meningeal artery is injured if there is injury directly on the lateral aspect of the skull, which leads a bleeding from the middle meningeal artery. So here, can anybody solve this MCQ? A 23-year-old female is brought to emergency room unconscious by a linear junction of 4 H-shaped suture. This is H suture, which is called as pterion. So which artery is injured, and this artery is a branch of which artery? So what is the right answer? No, that is middle cerebral. Anyone? The artery which will be injured is middle meningeal, MMA. And can you tell me middle meningeal artery is a branch from? That is middle meningeal artery. And we know that middle meningeal artery is a branch of maxillary artery. So yes, now I got a right answer from many of the students. Yes, middle meningeal artery, directly middle meningeal artery is not given in the option. They have given the source. The source will be maxillary artery. So see here, at the level of pterion, 4 bones meet and this will lead to the bleeding from the middle meningeal artery, which will lead to extradural hematoma. Yes. Yes, extradural hematoma. Muscles of tongue is a very important topic. So we have got following muscles. We have got following 4 muscles here. Genioglossus, styloglossus, hyoglossus, palatoglossus. All these muscles are supplied by hypoglossal nerve except palatoglossus by the vagus nerve. Now here these are extrinsic muscles. These are extrinsic muscles of tongue and these are intrinsic muscles of the tongue, and action of these muscles are important and nerve supply. So all the actions are important, but most common is the action of genioglossus muscle. Genioglossus muscle is called as safety muscle of tongue. Why? Because it is the only muscle which is causing protrusion of tongue. This is the one muscle which causes protrusion of the tongue. So it prevents the tongue from falling backwards. So it is called as safety muscle of the tongue. Yes, dear. So it is called as the safety muscle of the tongue. Yes. Yes, dear. And this is the nerve supply, everyone. So we can know all the muscles are supplied by 12th cranial nerve except palatoglossus by the 10th cranial nerve. Anterior part of the tongue gives sensory innervation via lingual nerve and taste fibers via coda tympanic nerve. The circumvallate papilla and the posterior part of the tongue is getting innervation from glossopharyngeal nerve, and posterior most part is getting innervation from vagus nerve. So go through this image showing you the innervation of the tongue, motor and sensory. If there is injury to the tongue muscle or genioglossus, it will lead to deviation of the tongue to the same side. So it will lead to the deviation of the tongue to the same side, that is ipsilateral deviation of the tongue due to paralysis of genioglossus muscle. Now, a patient is drinking hot tea. Yes, very good. A patient is drinking hot tea. Hot tea means general sensation. When I am using the word hot tea, it means general sensation. So can you tell me general sensation of anterior part of tongue is given by which nerve? General sensation of anterior part of tongue is done by which nerve? Lingual, absolutely right, lingual. And we know that lingual nerve is a branch of trigeminal nerve. Lingual nerve is a branch of mandibular nerve, and mandibular nerve is a branch of 5th cranial nerve. So that is the right answer. So that is the right answer. Now, this images of neuroanatomy. So this, can everybody identify what is this? Dura mater. So this is a fold of dura mater. What is this? That is flux cerebri. What is this? This is flux cerebri. So this is lying between the two cerebral hemisphere. This can come as an image based question. Now here in this diagram, you can see this is flux cerebri. This is flux cerebri, and which is meeting up with the tentorium cerebelli. It is meeting up with the tentorium cerebelli. And this is enclosing straight sinus. So this is the posterior view of tentorium. So the location of tentorium cerebelli is between the cerebral hemisphere above and cerebellum below. Now, let's see the location of flux cerebelli. It is located between cerebellum hemisphere. Cerebellum. And diaphragma sella is containing which gland, dear? Pituitary gland. It contains pituitary gland. You can see diaphragma sella is having a gap through which passes stalk of pituitary gland. Through which passes stalk of pituitary gland. Okay. Now, it's important for you to know all the dural venous sinus, superior sagittal sinus, straight sinus, transverse sinus. So actually, one important point is great cerebral vein of Galen drains into straight sinus. It drains into straight sinus. So yes. And this is the junction of the sinuses. Okay, so just go through the images because image-based question can be asked. Okay, okay, dear. Now I want you to know about cavernous sinus. Cavernous sinus is located in middle cranial fossa. Cavernous sinus is located in middle cranial fossa on either side of body of sphenoid bone. Body of sphenoid bone. On either side of body of sphenoid bone. On either side of body of sphenoid bone. Now, I just want everybody to see this image. This is showing you cavernous sinus relations. So all of you note down. Actually, medially cavernous sinus is related to pituitary gland, sphenoidal air sinus. So that blue structure is cavernous sinus, and internal carotid artery and abducens nerve is passing. If you will see this diagram, you can see internal carotid artery and abducens nerve, that is the sixth cranial nerve, is passing through cavernous sinus, and in the lateral wall, we have got oculomotor, trochlear, ophthalmic. Maxillary nerve is now not considered. According to Gray's anatomy, maxillary nerve is not considered as the nerve related to the lateral aspect in the cavernous sinus. Okay, so this is showing you the relations of cavernous sinus, and this is showing you the tributaries. Very, very important for your examination. Tributaries means they are carrying directly blood to the cavernous sinus. So cavernous sinus is receiving blood from three sources: from orbit, superior inferior ophthalmic vein, central vein of the retina; from meninges, middle meningeal vein, sphenoparietal sinus; and from brain, that is inferior cerebral vein and superficial middle cerebral vein. So this is important for your examination. And what will happen if the cavernous sinus is infected? It will lead to cavernous sinus thrombosis, and this will cause internal ophthalmoplegia. It will cause internal ophthalmoplegia. So now itself, I have shown you that all the cranial nerves, All the cranial nerves supplying extraocular muscles is paralyzed. Extraocular muscles is paralyzed. Okay. Next important topic for your examination neuroanatomy is the foramens. So we have to know all the important foramina. So in the anterior cranial fossa, the most important foramina is cribriform plate. Also there will be FC, foramen cecum. And there will be two foramens anteriorly, anterior ethmoidal foramen, posterior ethmoidal foramen. In the middle cranial fossa, you have to know about the superior orbital fissure, foramen rotundum, foramen ovale, spinosum, and lacerum. In the posterior, we have to know about foramen magnum, hypoglossal canal, internal acoustic meatus, and jugular foramen. Now, what is important is to know the structures passing. So, let's write. So, what structure passes through? Cribriform plate of ethmoid bone. So, the structures passing through cribriform plate of ethmoid bone. Olfactory nerve rootlets. What passes? Olfactory nerve rootlets. What passes through foramen cecum? Emissary vein. What passes through anterior ethmoidal foramen? Anterior ethmoidal nerves and vessels. And what passes through posterior ethmoidal foramen? Posterior ethmoidal nerves and vessels. Okay, posterior. These are the structures which is passing through anterior. Yes, dear. Edema of eyelid. Yes, there will be actually edema of eyelid, congestion, breaths, exophthalmos, many important structures, many important clinical features. But most important clinical features will be the internal ophthalmoplegia. Very good. Now, structures passing through middle cranial foramens, we will have foramen rotundum. What passes? ME, maxillary nerve and emissary vein. What passes through foramen ovale, male, MALE, foramen ovale, male. So M for mandibular nerve, A for accessory middle meningeal artery, L for lesser petrosal nerve, emissary vein. Okay. Now what passes through? Foramen spinosum, middle meningeal artery and nervous spinosum. What passes through? Optic foramen or canal, optic nerve and ophthalmic artery. Okay. Now we will have foramen lacerum, nerve of pterygoid, nerve to pterygoid canal. Nerve to pterygoid canal. Now, superior orbital fissure, as you can see, this is the superior orbital fissure as seen in the orbit. An important structures passing, I have already written it. Actually, superior orbital fissure is divided into three parts by the common tendinous ring. So, structures passing from the upper part is LFT. What is LFT? Lacrimal frontal and trochlear nerve. Lacrimal frontal trochlear nerve along with superior ophthalmic vein and branch of lacrimal artery. Middle part, The oculomotor nerve, abducen nerve, and nasociliary nerve. The both of oculomotor nerve, nasociliary nerve, abducen nerve, and through inferior part or medial part, inferior ophthalmic vein. Okay, all these, my dear students, this notes which I will give it to you, just go through this. This is very important before the examination. Now, posterior cranial fossa, we have got hypoglossal canal. So what passes through hypoglossal canal, my dear students? 12th cranial nerve. What passes through internal acoustic meatus? Seventh cranial nerve, eighth cranial nerve, labyrinthine vessels. Labyrinthine vessels. Now, structures passing through jugular foramen. So actually jugular foramen, yes, dear students. Nasolacrimal duct, no, there. Okay, dear. So basically, if I am talking about jugular foramen, it is again divided into three parts. Inferior petrosal sinus, 9th, 10th and 11th cranial nerve passes through middle part, and through the lower part or posterior aspect, sigmoid sinus joining with internal jugular vein passes. So you have to go through the structures passing through jugular foramen and structures passing through foramen magnum. So this big foramen, this big foramen is foramen magnum. It is divided into anterior and posterior part by the attachment of alar ligament. Now, structures passing. So, anterior part, only ligaments passes, apical ligament, cruciform and membrana tectoria. So, it is called as osteoligamentous compartment. So, the posterior part of foramen magnum, nerves and vessel passes. So, the posterior part of foramen magnum, nerves and vessel passes, that is lower part of medulla oblongata, accessory nerve, anterior posterior spinal artery and tonsil of cerebellum. Now, I also want you to see this sagittal section of the brain in which you can appreciate this is lateral ventricle. Lateral ventricle will communicate with the third ventricle via interventricular foramen of Monro. And what is this structure? This will be fornix. This structure is fornix. The third ventricle will communicate with the fourth ventricle via cerebral aqueduct. And then it will communicate with the central canal of medulla. Now, this is showing you circle of Willis. So, I just want everybody to know that circle of Willis formation. So, circle of Willis is formed by following arteries. It is formed by posterior cerebral artery posteriorly. It is formed by posterior communicating artery posterolaterally. It is formed by internal carotid artery laterally. It is having anterior cerebral artery anterolaterally. And it is formed by anterior communicating artery anteriorly. So this is the boundary of circle of Willis. And please note down, middle cerebral artery is not taking part in formation of circle of Willis. In this image, you can see middle cerebral artery is not taking part in formation of circle of Willis. Okay. Now actually for the neuroanatomy part, three syndromes are very necessary. One is Brown-Sequard syndrome. What do you understand by Brown-Sequard syndrome? Hemisection of spinal cord. So it is a condition of hemisection of spinal cord in which there will be three abnormalities. There will be pyramidal tracts or there will be paralysis. So the patient will have paralysis, upper motor neuron paralysis. The patient will have loss of proprioceptive sensation and the patient will have loss of pain and temperature sensation. So the patient will have loss of pain and temperature contralateral side and same side paralysis and that of loss of proprioceptive sensation. So that means ipsilateral side spastic paralysis and loss of proprioceptive sensation, and contralateral side of temperature and pain sensation gone. This is the case of Brown-Sequard syndrome. Two other syndromes is asked in examination, which is important for your examination. One is lateral medullary syndrome and other is medial medullary syndrome. So if I talk about most important brain syndrome, which will be asked in the FMG exam, my dear students, that is medial medullary and lateral medullary syndrome. In lateral medullary syndrome, dorsolateral part of the medulla is involved, and in medial medullary syndrome, medial part of medulla is involved. So medial medullary syndrome is also called as Digener's bulbar syndrome, and basically the injury is due to the vertebral artery. Only three important features are there. Actually, medial part of medulla is involved and three important structures are damaged. Hypoglossal nerve nucleus. And we know that hypoglossal nerve nucleus means 12th cranial nerve. Means all the muscles of tongue is paralyzed. Contralateral hemiplegia because of corticospinal tracts paralyzed in the pyramid, and loss of position and vibration sensation because of involvement of medial lemniscus. So these three signs and symptoms are present in Digener's or medial medullary syndrome. If I am talking about lateral medullary syndrome, which is also called as Wallenberg syndrome, so it is also called as Pica syndrome. It is also called as Wallenberg syndrome. There is injury of vertebral artery or Pica artery. Actually, in the dorsal lateral part of medulla, many structures are there. There is trigeminal lemniscus, that means sensation of face is gone. There is lateral spinothalamic tract, that means sensation of opposite side of the body gone. There is nucleus ambiguous, that means muscles of palate, pharynx, larynx gone. There is sympathetic fibers going, so Horner syndrome. There is vestibular nuclei, so balance gone. Okay, so see here the features are contralateral. So actually it is very, very important for you to note down that opposite side pain and temperature will be gone. Contralateral pain and temperature is gone due to involvement of spinothalamic tract. Same side temperature sensation of the face gone due to trigeminal nucleus. Paralysis of the muscles of tongue, paralysis of the muscle of palate, pharynx and larynx. Cerebellar peduncles, so there will be no balance, ataxia, giddiness and Horner syndrome. So these are the features of lateral medullary syndrome. Same thing is three features in the medial medullary syndrome. So many features in the lateral medullary syndrome. After that, we have finished the important topics of neuroanatomy. The last thing is the embryology part. For embryology, what things you have to pay attention is the arches, pharyngeal arch derivative. So basically, I want you to describe, if I'm talking about arch derivatives, pharyngeal arch, first pharyngeal arch is the muscles of mastication, mandibular nerves, and the incus and malleus. Okay, we have got the ligaments of the ears. Then in the second pharyngeal arch, we have got the muscles of facial expression. We have got the facial nerve. In the third pharyngeal arch, the nerve is glossopharyngeal nerve. Fourth, sixth arch, the nerve is recurrent laryngeal nerve, superior laryngeal nerve, and the muscles of larynx and pharynx. So actually, all these are very, very important. Go through this pharyngeal arch. Same comes the pharyngeal arch artery. So pharyngeal arch artery derivative is also been asked. I just want to tell you about pharyngeal arch artery. How you are going to memorize this? Now I have memorized like this. First arch, mandible. First arch artery, mandible, because first arch artery, maxillary. Second is hyoidal and stapedial. Third is common carotid, internal carotid. Fourth is aortic arch and the subclavian artery. And sixth is ductus arteriosus and pulmonary artery. So you will go from above to down. So we know that different arteries has got different source of development. How I am going to memorize it? I am going from above to down. So we know maxilla is above. So maxillary artery, hyoidal and stapedial is the second arch artery. IC, internal and common carotid artery, third. Arch of aorta slightly lower down, fourth, and sixth arch artery, lungs, pulmonary artery and ductus arteriosus. Also go through the derivatives of pouches. First pouch is tympanic cavity. Second pouch is tonsil. Third pouch is thymus and inferior parathyroid gland. Fourth pouch is superior parathyroid gland. At the end, I also want you to know about the cavities and the brain vesicle. So basically, if I'm talking about the forebrain, it is called as prosencephalon, which is again dividing into diencephalon and telencephalon. So telencephalon will form the cerebral hemisphere. Diencephalon will form thalamus, hypothalamus, epithalamus. The cavity of hypothalamus, the cavity of diencephalon, that is hypothalamus, thalamus is third ventricle. The cavity of cerebral hemisphere is lateral ventricle. Mesencephalon will form midbrain, and the cavity of midbrain is cerebral aqueduct. Rhombencephalon will form mitten and myencephalon, that will form pons, medulla, cerebellum. And the cavity which is lying between the cerebellum posteriorly and medulla and pons anteriorly is the fourth ventricle. Okay. So basically you have to go, and I also want you to go through derivatives of germ layers, derivatives of germ layer. So you should also go with the important topics as derivatives of germ layer. So we have finished the important topics. What I have done, I have already gone through the whole anatomy in detail, where I have taken the 4 days class, 3 days classes, and also in the online session, I have given approximately more than 30 hours anatomy, 32 hours, 34 hours anatomy, and much details we have taken. Now the time has come that in 3-4 hours, most important topics should be done. So I have gone slightly faster. I want to give all my blessings to my dear students. Just go with these topics. And if you have got time, you can go for more topics, but don't go with new topics in the last 1 month. Okay. So all the best. Keep studying, and my blessings are with you. You are going to crack the examination. Have faith in yourself. Just go and crack the examination. Whatever thing you have studied, just revise that. Not start with new topics. Just go and revise that. You have to secure 50%. That